ASEAN Event and Personal Data Protection Act may vary from country to country. Please refrain yourself from recording the session. Recording any individual without consent is against the Personal Data Protection Act 2012. You may review the recorded session in PEP Connect in the future. Please be reminded that the following hypothetical case scenario is solely an educational exercise and does not necessarily reflect the real clinical pathway in any healthcare institution. Without further ado, let's get started.
Good morning, Mr. Hajime. It's been a while since I last saw you. A very long time. So, how may I help you today?
So good morning, doctor. So yeah, I think I'm done with the bug. So I feel tired all the time these days. Whenever I climb the stair or try to do some activities, I experience shortness of breath and chest pain. So I've lost my job since COVID started. So since then, I have led a sedentary lifestyle, just eating, watching YouTube every day. So I want to check if there's something wrong with me. And I had another episode of chest pain and breathlessness after running to catch the bus in this morning.
I see. I'm looking at your personal file and I definitely do have.
It's so boring watching TV all day. I got to puck per day. So now since I got nothing else to do, I retired now.
All right, Mr. Hajime. One step at a time. So, I will do a quick blood test for you now. And while waiting for the results, I will need you to walk over there to the radiology department to do a chest x ray. From there, we will see what we know about your condition and plan accordingly, all right?
Okay, doctor.
Cardiovascular diseases remain the biggest cause of deaths worldwide. One of the most important diagnostic tools clinicians have for the timely diagnosis of acute myocardial infarctions is cardiac troponin. Siemens Healthineers provides fast, accurate, and actionable test results with a true high-sensitivity cardiac troponin I assay.
Over the past several years, we've never seen customer needs and clinical guidelines evolve so quickly during the development process. Our development teams, who collectively have over 75 years experience developing cardiac assays, have combined the feedback from leading global cardiologists, emergency room physicians, and laboratory experts to ensure our high sensitivity troponin I assays not only meet healthcare providers' clinical needs, but are also reliable and robust.
This is my third troponin assay. Every time the bar has raised in clinical needs, we push the current technology to perform, and this is no different.
Siemens Healthineers' advanced acrodinium ester, or AE technology, enables our developers to choose a tailor-made AE whose properties best suit performance requirements of the assay. We continue to develop and enhance our AE molecules, now resulting in over 50 granted or pending patents. The high sensitivity troponin I assay incorporates our brand new TSPAE, which has a strong anionic label with the same high light yield as HQYAE and very low nonspecific binding.
In addition to the new acrodinium ester, our proprietary monoclonals have binding affinities of 10 to the 13th. High-affinity monoclonals are essential to achieve both the accuracy and precision at troponin I concentrations encountered in normal, healthy individuals. The architecture of the AE conjugate is unique. TNIH employs a maleimide-activated BSA-TSPAE to couple a recombinant Fab monoclonal through cysteine residues. The resulting conjugate has very low NSB, nonspecific binding, and high RLU, or light output, per binding event. The TNIH design also includes a preformed magnetic latex polyphase reagent consisting of two monoclonals. This design eliminates bias and interference, especially important for kidney dialysis patients, many of whom are on biotin therapy.
In addition to satisfying these rigorous technical aspects, the assay has been designed for robust manufacturing by employing the principles of Six Sigma design.
Maintaining standardization lot after lot, year after year, is challenging but essential. Our internal troponin I anchor standards are cryogenically stored and used to solely value assign gold standards, which in turn are used to value assign master curve standards. 5,000 to 6,000 sets, enough for several decades, have been manufactured.
For clinicians trying to triage patients with levels lower than the 99th percentile, this extra sensitivity gives the confidence that slight but subtle changes can be biological, not analytical noise.
The sensitivity of the TNIH assay is tenfold greater than the TNI Ultra assay, which is a guideline acceptable assay. Visually, this is easily seen by comparing the precision curves for the TNI Ultra to the TNIH assay. The comparison essentially speaks for itself.
And now, to give clinicians even more tools to effectively treat patients, the assay has separate sex-specific 99th percentiles available. The Siemens Healthineers Troponin I assay offers improved cardiac patient care. It is a true high-sensitivity troponin I assay that meets the current guideline recommendations.
Over a decade ago, we pushed the industry ahead with the Advia Centaur TNI Ultra assay. This time around, we have put every effort into this assay design, and it will move the industry forward to support patient care for AMI and beyond.
I never thought I'd say third time's a charm, but this time I'm pretty confident that this high-sensitivity troponin assay has been designed to meet the needs of today and tomorrow.
Thank you very much for your kind introduction. My name is Yến, and I take responsibility for XP application in Vietnam. And today, I'm very honored to be here and have a topic to share with you about routine chest X-ray. Come back with our patient. So here at the radiography room, we have the first conversation. A little bit in an intro before I go to more detail. I understand that there are a wide and diverse audience. Maybe you are a medical student or very experienced radiographers or radiologists, or even you are a healthcare investor. With this topic about routine chest X-ray in positioning and procedure, this should be very common topics that you would meet every day in your workflow. Maybe you work with your own setting. Maybe it's not all the same of us. So when I build this content, I do hope that this will bring to you valuable and opportunities to challenge your understanding and well-established practice. Definitely something I thought here that you already know or already did. Then yes, here I have a message in my topic. Routine chest X-ray, positioning and procedure. Is it a piece of cake? Is it very easy for everyone? In the next minute, I will go through mainly 4 parts. The first part is about the X-ray physics, just a brief review. Then we will go to the second part, talking about indication of the chest radiography, which also include the question for positioning we will do today for Hajime. PA or AP. And then the workflow in the jet examination will be mentioned in the fourth part, which is here is my main focus of my presentation. So it will take longer. Therefore, I have some interesting topic here. How to communication effectively with our patient, Mr. Hajime, some tips to optimal chest PA in positioning and imaging. Of course, with our patient today, we have some challenging and how to overcome it. The last one is evaluation. How to know this image quality is good. That is on the topic. In the third part, and the final part is how can a modern X-ray system help you? I believe that this part will be very excited because I understand that there may be some challenging for us radiographers have facing in our workday. And this part will show you some solution to help you overcome it. The system going with me in this part is ISO X3 with my exam companion, a leap forward in intelligent X-ray imaging, and also with support from AI Red Companion Chest X-ray. Okay, let's go to detail. Firstly, I will go through a brief overview about X-ray physics. In the 1895, a physicist named Wilhelm Röntgen was doing experiments with a cathode tube, a glass container in which a beam of electrons and this lights up a fluorescent window. Wilhelm had no idea what those rays were, so he called them X-rays, and his discovery eventually won him a Nobel Prize. Here's what was happening in a cathode tube to produce the X-ray. When a high-energy electrons in the cathode tube hit the metal component, they either got slowed down and released extra energy, or kick off electrons from the atom they hit, which trigger a reshuffling that again released energy. In both cases, the energy was emitted in the form of the X-rays, which is a type of electromagnetic radiation with higher energy than visible light and lower energy than gamma rays. The X-rays are powerful enough to fly through many kinds of matter, and they are especially beneficial in medical applications because they can make images of organs like bones, and when X-rays interact with matter, they collide with electrons. Sometimes the X-ray loses all its energy and is absorbed by the substance. Other time, it only transfers some of its energy and the rest is scattered. The frequency of this outcome depends on how many electrons the X-ray are likely to hit. The collisions are more likely if material is dense, which means are more electrons. Bonds are dense and full of calcium, which has a relatively high atomic number, so they absorb X-ray pretty well. Soft tissue, on the other hand, isn't as dense and contains mostly lower atomic number elements, like carbon, hydrogen, and oxygen. So more of the X-rays penetrate tissues like lungs and muscles, darkening the radiography. That is a brief principle of X-ray and how X-ray can imaging and showing the organ. Nowadays, there are three main general types of X-ray systems for radiography. One is the mobile X-ray system. It is on the left. As you can see, this system with very friendly designs. Its name is Mobilet LRM Max. In the middle, you can see a setup of a floor-mounted X-ray system. The system I put in this image is Multix Impact, and then the ceiling mounted X-ray system, EZO Max. In addition, we also have some X-ray system which can be used in multiple functions like fluoroscopy, such as luminous DIF Max, or 3D imaging between robotic X-ray. In Siemens Healthineers, we have fully portfolio for X-ray system for different demand applications. Every X-ray imaging system has three principal parts: the X-ray tube, the operating workstation, and the high voltage generator. In some types of X-ray imaging systems, such as mobile X-ray, these three components are housed compactly. That is three principal parts of radiography system. However, in present day, there are a lot of additional parts, accessories that support in examination and cannot ignore in a radiography room, such as bulky stand, detector, table. Then with the most systems, the X-ray tube is located in the examination room and the operating workstation is located in an adjoining room with a protective barrier separated of the two. The examination room, the tube can be designed in the two-way, floor-mounted tube or ceiling-mounted tube. The part of the X-ray imaging system most familiar to radiographer is the operating workstation. The operating workstation allows radiographer to control the X-ray tube current and voltage so that the useful X-ray beam is of proper quantity and quality. The radiation quantity refers to the number of X-ray to the intensity of the X-ray beam. The radiation quantity is usually expressed in milliray or milliampere per second. Normally we call the MAS. Besides, the radiation quality refers to the penetrability of the X-ray beam and is expressed in kilovolt per kVp and also in workstation. Radiographer can manage patient data, register patient archiving, sending, or beam printing. Compared with other modalities of imaging, jet radiography has many advantages. It offers simplicity, low cost, low radiation, large amount of information, and is widely available throughout the world. And especially recently, the virus named SARS-CoV-2 expanded globally and jet X-ray became an essential first-line tool in the COVID-19 pneumonia diagnostic and management. Then, what is the indication of jet radiography? Periodically, scientific societies edit guidelines for the performance of jet radiography to assist practitioners in providing appropriate radiological care for patients like ACR, American College of Radiography, or the Society of Pediatric Radiology, SPR, and the Society of Thoracic Radiology. Those guidelines are evidence-based but differ by country, according to socio-economical factors and technical developments. So here, there are 6 major indications. 1. Chest pain presents one of the most common causes of admission to the emergency department. According to ACR chest radiography is the recommended initial imaging study. Evaluation of signs and symptoms potentially related to the respiratory, cardiovascular, upper gastrointestinal, and thoracic musculoskeletal system. Number 2, the patient's follow-up. Even the chest radiography is less sensitive than the chest CT in detection of various disorders, but with these characteristics like low radiation dose, excellent cost-benefit ratio, accessibility, and speed, chest radiography is still the most commonly used imaging tool for follow-up. Number 3, position of catheter and thoracic devices. In some instances, CT can depict more accuracy the course of the catheter or the relationship of the medical device to the anatomical structures. Unfortunately, in this situation, CT is often limited by the presence of metallic artifacts generated by the device. The chest radiography should remain the standard of care. Number 4, the patient is intensive care unit. Number 5, for lung cancer screening. However, this indication is still controversial. Even at present, screening with chest radiography has been abandoned in most of countries. Instead of that, the role of a low-dose NDCT in this field is more and more proven in lung cancer screening. Number 6, pre-operative patients. Any unexpected abnormalities can be found in preoperative chest X-rays. Most thoracic abnormalities reflected chronic disorders, and the contraindication of chest X-ray is for the pregnant or potentially pregnant patient. Then posterior anterior PA or anterior posterior AP. In chest examination, the doctor mainly focuses in the heart and lungs. Therefore, the target is prevent the engorgement of pulmonary vessels and to allow gravity to depress the diaphragm, as well as the need to show the air and fluid levels. For the best results, is the patient should be positioned upright, meaning the patient should standing or seated. So the diaphragm is at its lowest position and permit visualization of air and fluid levels. The projection is divided by the direction of the X-ray beam to the patient. And here we have two terminology, posterior anterior PA or anterior posterior AP. The first image illustrates the direction of the X-ray beams. The X-ray beam is come from the behind the patient, meaning posterior, and go to the front of the patient, meaning anterior. So we call this view is posterior anterior PA. The anterior front aspect of the patient chest placed closest to the detector for posterior anterior projection. In an AP X-ray, which is explained in a second image, that the X-ray machine is in front of the patient and the detector is at the back. So the X-ray beam came from the anterior to the back posterior. And here, compare with PA view, the heart closest to the detector. So it reduces the cardiac magnification and the risk of producing a lordotic image as the patient is likely to lean backward. Therefore, the PA projection allows accurate evaluation of the cardiothoracic. The distance between the tube to the detector, we call it SID. And the SID from 180 centimeter is recommended to decrease the magnification of the heart and increase the recorded detail of the thoracic structures. Here is the clinical image, how the chest AP and the chest PA look like. For the chest AP projection, the patient is lying in position and the heart become more magnification and the mediastinum become widening, and also lead to alteration of the pulmonary vasculature, whilst the distance from the X-ray tube will also become less than 180 centimeter, which will increase the effect of the beam divergence, for example, magnification. The AP chest normally performed whenever the patient cannot come to the department for traditional PA to follow abnormalities and to evaluate clinical support devices which the patient cannot take the upright positioning. Maybe you can see this projection used in ICU department, normally taken by mobile X-ray, or in emergency case, which is the patient in schedule trolley like this, and we need to pull out the X-ray tube to release X-ray. Comparison between this, the PA examination can remove all the shadows of the scapula from the lungs fields, and it adapts on the recommendation of a standard chest examination. It's performed in the erect position on full inspiration, a distance of approximately 186 feet from the X-ray tube. Therefore, the PA projection is considered to be a gold standard examination. For this reason, a standard examination should include an erect PA. In some guidelines, they also included left lateral projection as a standard chest examination. However, these guidelines differ by country, and in this topic today, I will share with you the most of routine chest examination in my country is chest PA. This is a standard workflow of a chest examination. As on the imaging procedure, we need to communicate with the patient at first to guide them how to prepare before the examination and what they need to do during the examination. Then after that is positioning and operate the system. In this part, I will share with you about the technique and the challenging with our patient today, Mr. Hajime. Then next is imaging processing. You will get a live demonstration of image processing in ISO X3 through Smart Simulator. The last step is the workflow in documentation. In this step, the radiographer will send the image to radiologist. And here I will introduce about AI-RAD companion chest X-ray application. Before I go too deeper, I want to share this number. In the Journal of the American College of Radiology, a study about patient satisfaction in radiology have the conclusion in this study like this. The most common complaints from radiology patients concern a lack of patient-centered care, which takes about 60% failure to provide patient-centered care, over half. So whatever you do in an examination, first we need to know about our patient. Mr. Hajime, he is 62 years old and he is quite obese due to inactivity and unhealthy diet. With these characteristics, we might have these challenges. First, communication and emotion impact. For the obese patient, they are more sensitive about their body, their weight. When doing healthcare imaging, they are more embarrassed. Then that emotion impact will lead them to be difficult in communication as well as position. In addition, imaging also be challenged with obese patients. To get effectively in communication, there are some notes that we need to do and need to avoid. So first is something we need to do. Good communication and listening skills create a connection between the radiographer and patient. So please speaking slowly, directly, and distinctly when giving instruction. This will make our patient, especially older adult, easier to sort through directions and improve their ability to follow them with better accuracy. When moving and adjusting a patient into position, the radiographer should manipulate the patient gently but firmly. A light touch can be as irritating as one that's too firm. A kind, friendly attitude and approach to elder patient result adjusting and cooperating patient. Actually, obese people are unique and they should be treated with dignity and respect. So what we need to avoid? I know chest X-ray is routine for you, but not for the patient. So the entire procedure may be a new experience for the patient. Patient usually respond incorrectly when given more than one instruction at a time. For example, when instructed patient, please go to the buccal stand and facing to the detector, the patient may do the opposite. They will go to the buccal stand, then having their face facing to the X-ray tube, and turn his back on the detector. Instead of asking the patient to go to position by his own in a specific position, we should first have the patient stand next to the buccal stand and then giving instruction on assuming the desired position. I have experienced some situations that radiography only guide patient through the intercom and patient have to do positioning by themselves. Actually, this takes more time for you to do like this because the patient sometimes not cooperate well. Moreover, if the patient do it by themselves, the position can be assumed with less strain and fewer outward movements. So please don't let the patient to do position by themselves. The radiographer should never rush a patient. I understand that you have a huge number of patients to do every day. If the patient feel hurried, they will be nervous and less able to cooperate. This also takes time for you to do positioning, might be also affected to image quality. There should never be any discussion about patient in radiographic room and no discussion within hearing distance of the patient about poor image quality or difficulty in obtaining image. And please avoid to use any word which leads to body shaming with the patient. For example, fat, big, overweight. Yes, the obese patients are unique and you need to treat with respect. One more step that we cannot skip before we start positioning is patient preparation. It is extremely important for ensuring image quality and avoiding repeat radiation. Remove all the metal objects in thoracic area, especially some patients have pocket in their shirt like this, and they might put inside a mobile phone, glasses, and necklace. So to ensure there is no suspected to cause artifacts, ask the patient to change to hospital clothes. Short button, twinkle decoration on clothes, they also might appear on the image and this may make artifact. So please carefully. If the patient have a long hair, hair should be gathering and keep it in a high place by hairband. On the action here just to prevent anything might visualize and cause mistake to the diagnostic. Okay, we go to the main part of the workflow, positioning. To get the optimal HSPA positioning, we need to follow through 4 steps. First, technical requirements. Ensure detector available. For some systems only have one detector and you put in the table. Ensure that you change detector to the buccal stand. I have experienced sometimes radiographers forgot to change the detector. After they do all the steps, they realize that they forgot to put the detector on the buccal stand. Then they have to do again. This leads to double radiation for the patient. I know nowadays this case is rare. For example, with Siemens radiography system, it will not allow you to exposure if you not put the detector on the right position. But just be careful because maybe your system you're doing cannot control of that. As well as careful to handle with the detector in changing places. If you using detector size 35 and 43 centimeter, make sure that you put in the right direction of the detector suitable with the patient body. I will talk about this in the next slides. If you have fixed detector in buccal stand, normally the size of fixed detector is 43 and 43 centimeter, then yes, it's easy for you now, but you still need to ensure that the grid is in, and SID recommendation for the chest X-ray is 180. I know some situation about the room condition and you cannot allow to extend SID to 180. Then please make sure the minimum SID should not less than 150 centimeter. Established right SIDs is recommended to decrease the magnification of the heart and increase recorded detail of the thoracic structure. Then when doing positioning, patient is in the upright position. Have the patient stand straight with the weight of the body equally distributed on the feet. Adjust the height of the buccal stand so that its upper border is about 4 to 5 centimeters above the relaxed shoulder. A slight amount of radiation from the PA causes considerable distortion of heart shadow. To prevent this distortion, the body must be carefully positioned and immobilized. Place the patient with arm hanging at the sides. Actually, the traditional posterior anterior the PA position is to have the backs of the hand on the hips. This may be difficult to someone, especially older patient with impaired balance and flexibility. So you can allow the patient to grab his arm in the handle of buccal stand as a means of support and security. Adjust the height of the detector so that its upper border is about 4 to 5 centimeters above the relaxed shoulder, and ask the patient to extend the chin upward. Guide the patient to relax the shoulders and adjust to lie in the same transversal plane. These movements will position the clavicle below the apices of the lungs. Rotate the shoulders forward. This movement will rotate the scapula outward and laterally to reduce the superimposition of the scapula with the lungs. Make sure center the mid-sagittal plane of the patient equal with the midline of the detector, or you can check by the center line of collimator. In the step 3, radiation protection. Protection of the patient from unnecessary radiation is the professional responsibility of the radiographer. The patient is to be protected from unnecessary radiation by using proper collimation and the placement of the lead shielding. This is an example of properly placed lead shield. When talk about chest X-ray, and one senior radiologist said that the chest X-ray is a contrast technique. The contrast agent is air, and I really like the way he compared about it. Yes, the reason we can see soft tissue structure on chest X-rays is the presence of air contrast. So please don't skip this step. Instructing the patient of full inspiration is very important. There is a tip here to get a full inspiration that the exposure is made after the second full inspiration will get the maximum expansion of the lungs. At last, when making the final adjustments to a patient position, we should stand with the eyes in line with the position of X-rays to visualize the internal structures and adjust the part accordingly. To get optimal image for obese patient, make sure that the grid is in. This is how you can see the grid in buccal stand. You can slide down in some examination that not needed, for example in pediatric exam, but here in the chest PA on the obese patient, we need to check whatever is in or the status of the grid or in the system is available or not. This image is illustrate that the system did not recognize the grid. So that the message shown in the tube here, check grid. This is an image demonstrating the difference between using grid and without grid. So as you already know that grid is to reduce the scatter radiation reaching the detector and thus improve the image quality. So grid plays very important role in image quality, especially with the obese patient. Come back to our patient today. The BMI actually is not of primary importance. When radiographic examinations are performed, the patient's body diameter and weight are the two important considerations. The general shape of the human body, or we call the body habitus, determines the size, shape, position, and movement of the internal organs. So in the chest examination, we should Observe the patient's body habitus. This will be helpful in positioning accuracy for projection of the thorax, especially with the patient hypersthenic, meaning the patients who are barrel-chested or obese. With this characteristic, heart is axis and nearly transverse. Lungs is short, the apices at or near the clavicles. The diaphragm is high. Therefore, the thorax is likely short, broad, and deep. If your detector size is 35 and 43 centimeters, then you might get missing image here. If you put the detector on vertical direction, we should change the direction horizontal way. This is more suitable for obese patients. One of the most important considerations in positioning an obese patient is the need to recognize that the body skeleton and most organs have not changed in position and the organs are not larger. Most of what you see physically on this patient is fat. Although the soft tissue dimensions of the patient B are much greater than those of patient A, the skeleton of patient B is approximately the same size as that of patient A, and most organs are located in their normal positions. The only exception would be seen in obese patients in whom the width of thoracic cage and the ribs may be expanded a little than patient B. I understand that you may be tempted to use the maximum size of collimation on large patients. But believe me, this very large collimator setting produces more scatter, which degrade over image quality. The more you open collimator, larger is just make more scatter and more dose. But the size of the detector is limited. It does not cover as same as you open the collimator. Just remember, the collimator should never be set larger than the size of the detector. In Siemens radiography system, we have the function ACSS, the automatic collimation, in almost all the system. This assists you to control the collimator is not larger than the detector size. This saves a lot of radiation for the patient. Sometimes I get the question from the radiographer like this. The field size visually appears small on the top of the patient. The field of light they see may be not cover on the body, and they cannot open the collimator larger. So please remember that because the radiation field diverges, then the smaller field you see is because there is near the source, especially with the obese patient. So the system always will keep the right field with the size of the detector. Don't let your eye fool you. Conclusion for this slide, collimation is one of the most important considerations when obese patients are imaged. Setting the collimator to the smallest dimensions, possible reduced scatter radiation. The scatter radiation reduced, which will make the contrast increase, which able improve visibility of the structure. Indeed, a significantly improved diagnostic image is obtained on obese patients when collimation setting the appropriate size are used. The skill set used in radiography, located and palpate structures for imaging. And that is a huge challenge with the obese patient. A thick layer of adipose tissue obscuring body landmarks and hinder the accurate positioning, maybe making repeat projection due to positioning error more likely. That is why the ability to compensate is gained through experience. Most anatomic structures cannot be visualized directly. The radiographer must use various protuberances, tuberosities, and other external indicators to position the patient accurately. This surface landmark enable the radiographer to obtain radiographs of optimal quality consistently for a wide variety of body types. In some textbooks of radiography, that the centering point of PHS was at an idea that should enter at the level of the T7, the interferior of the angle of scapula, and here another way to figure out the center raise is about 3 inches, around 7 to 8 below the jugular knot. For very obesity patient, the jugular knot in here may be the only palpable landmark on obese patient, and with the chin raise, the jugular knot may be palpated. The radiographer should not aim to push and prod to find these landmarks. You can ask the patient to assist you in finding the landmarks if possible. This gives patient a sense of being involved in their examination. The patient should be informed of what the radiographer is doing every step of the way. For the technique of imaging chest X-ray, the proper technique for the chest radiography requires that the high KVP techniques be used. The high KVP reduces the contrast, presenting a greater image. The total information gained from the lungs and the mediastinum is greatly improved. This means the better detection of parenchymal densities overlying bone in the lungs and good delineation of tracheal and proximal bronchi and the mediastinal air soft tissue interface. The radiation dose absorbed by the patient is lower with the high kV technique, with the lower voltage range from the 80 to 90 kV. In some textbooks and guidelines, the kV was recommended as 125 kV. However, depending on your hospital setting, especially it is important to follow the manufacturer's recommendation of your system as well. Modified X-ray exposure techniques are needed to use on the obese patient. The major limitation on the obtaining imaging of the obese patients is inadequate penetration of the body part. This situation results in increased quantum motor noise and decreased the contrast resolution. And as I mentioned in the first part, the KVP determines the quality of the X-ray beam. So the most important adjustment that should be made in an increase in the KV beam. Increasing the KV, increasing the penetration of the X-ray beam. Yes, the use of manual selection of exposure technique factors sometimes result in poor exposures. The AEC are widely used in radiography departments to control technical factors automatically. The AEC is a device that measures the quantity of the radiation that reaches the detector, the image receptor. It automatically determines the exposure when the image receptor has received the required radiation intensity. The AEC device is a flat, parallel flat ionization chamber positioned between the patient and the detector. This chamber is made radiolucent so that it will not interfere with the radiographic image. The ionization within the chamber creates a charge. When the appropriate charge has been reached, the exposure is determined. Yes, nowadays, most of features are automatic, but the radiographers must know their purpose and proper use. After we exposure, what are the standards to evaluate the X-ray image quality? First, to correct the demographic information. Second, to correct the marker placement. Check the left-right marker. Do not assume that the heart is always on the left. You can set the system to put the marker automatically, but as traditionally, I recommend you to put the lead letter on the bucket within. Properly collimated include all the area of interest. The area from the C6 cervical vertebra to the upper abdomen with both costal brain angle and the soft tissue chest wall on the both sides should be clearly visible. It is good practice to collimate out laterally to the AC zone. Next is well penetrated. That means that you have to correctly expose. The vertebra with the intervertebral disc space are just visible behind the heart, and the branching vessels should be visible through the heart's shadow. And the properly positioned, not rolled or angulate, the medial end of the clavicle should be equidistant from the spinous process at the level of T4 or T5 thoracic vertebra and not obscuring the apices. In the normal image, the medial ends of the clavicle should be equidistant from the spinous process at the level of T4 or T5 thoracic vertebra and not obscuring the apices. In the normal image, the mediastinum and heart should be centrally located and sharply defined. We should have the full expression. The diagram should be visibly below the level of the 9th to 11th rib posteriorly or the 6th to 7th anteriorly rib. No blurring. The fine demarcation of the diaphragm. The borders of the heart and the lungs vessel, especially those in the lower lung. Scapula away from the lung. On the PA view, ideally the scapula should be away from the lungs, but overlaying only on the fifth of the periphery of the lungs can be acceptable if it's not covering any suspicious abnormality. And final, no artifact overlaying on the lungs. That is all the requirement when evaluating the chest X-ray. It seems that it's not so hard to achieve all of them, right? But here there is an interesting story about the error when they collect the data of chest image quality. In overall correct criteria, only 52% meet all the criteria, but remain about 47 was incorrect due to either of one of above or more than two reasons. That's huge. And what is the common error of chest examination? Can you guess? And the inadequate inspiration were the most common causes of errors. You may wonder why it is important to have a good inspiration on a chest radiograph. Dr. Aben from Michigan State University explained that if the patient does not provide an adequate inspiration, the lung marking become more crowded and the radiologist could interpret an abnormality that is not really there. Likewise, the heart shadow and the border are not adequately visualized without adequate inspiration. So the heart will appear larger than it is. Another reason is inadequate penetration, rotation, scapular not out of a lung field, and no anatomical coverage. So we have now about the challenges we might have when doing chest workflow. We go through what needed in a standard chest PA. And also we know what area we have got trouble with it. Then the question is, what is the problem here? We know all the obstacle, but we still struggle with it. Explain for this. In a survey of 104 technologies, 70% reported they have repetitive stress symptoms. And the primary causes is patient and imaging equipment. Patients are getting older and older, and this is time-consuming. Time-consuming in prepared examination, but also during aftercare. And patients also getting bigger and bigger, and this increased physical burden to achieve. Correct the patient positioning. Not only radiographer, radiologists, they also face with the workload pressure and really bad consequence here. 19% of lung cancer missed on the chest radiographs due to workload pressure. When we're facing with the trouble, with the stress, we cannot change what we cannot control. Patient condition, we cannot control that. How about our system? Wondering if you are operating your X-ray system at its full potential. How can a modern X-ray can help you? So we all know about the challenging of radiographers. They have a high workflow, and radiologists often they have a few seconds to read image and perform diagnostic. With easier X-ray allow to persist image for all the body region, reduce unwanted variation, which is user dependent. And therefore we have a few great features to introduce you today. So now have a look into the detail that functionality on ESO X-ray that could support you in a chest examination. MyExam 3D camera is a name of a hardware that ESO X-ray always included in. This is a part of basic configuration. With this 3D camera, you can see the live image of the patient on the workstation outside the examination room. So you can focus to the patient at all the time, making sure that they are doing fine and provide reassurance. And one more feature that can combine with MyExam 3D camera in the chest examination is MyExam Collimate. Enable you with these pioneering functionalities. First, virtual collimations means you can do collimate at the touch screen at the workstation. In my country, normally the radiography room will have 2 radiographers to manage the examination. One is on examination room for positioning, and one is in control room working with workstation. With this arrangement, the one who's sitting in control room have to wait until who is in the examination room have done all the step positioning, collimation, close the door, then he can release X-ray. And in virtual collimation, you can work on workstation to have your colleague as well save time. For both of you, if there's something wrong, patient movement, you can adjust right away without going to the inside. Second is the auto-thorax collimation. For AI-based thorax detection, the tube will alignment accordingly and collimation correctly at the region of the interest. Well, this can save a lot of time for radiographer as well as for safe dose for patient. Okay, let's find out these functions as well as overview on the content from the previous part about X-ray workflow in the next video.
Are thorax exams the most frequently performed procedure in your rad department? Even though it's a routine task, it can be time-consuming when patients need a lot of help. ESO X-Pre revolutionizes the way you perform thorax exams while interacting with your patients. It speeds up workflows by identifying the correct region of interest. Interactive guidance enables you to collimate correctly while staying with your patient. The MyExam 3D camera helps produce standardized chest images independent of the operator and patient, so that you can deliver the right thorax image with ease. ESO X-Pre, a leap forward in intelligent X-ray imaging.
I have made this process diagram to illustrate the workflow of a chest X-ray. You can easily compare between a standard workflow and optimized workflow with Easio X3 supported by my exam companion. In a standard workflow, you have to prepare your system at ready status like rotate the tube forward the bulky stand and move the tube to the right SID as 180 for the chest X-ray by manually. The patient come in, you do positioning, then you have to adjust the tube to be at the centering the chest and collimator. Next, go to control room and release X-ray. This is just a normalized workflow. If something wrong happened in examination room, for example, patient move, wrong collimator, you have to go inside to adjust again. So what I have seen a lot with a huge patient workload, the radiographer is not change collimator for each patient. Sometimes they skip collimation step. Therefore, with this workflow, not only take longer exam time, but also patient might get more dose. And after we have watched the video demonstration the chest X-ray workflow from the previous slide, so here is the step when we're doing exam on Easio X-ray. Just as one press of the button, the tube will automatically move to the position right SID, as well as the right at the center of the bucket stand. Then once the auto thorax collimation active, when you do positioning for patient, the tube is collimator for you automatically, as well move to the center accordingly. And you just check again. Even in control room, you can see through the workstation. Adjust if needed, then release X-ray. Of course, this takes shorter time and the patient get the right dose. Compare with the standard that I mentioned above. Definitely, it takes less dose than. And next, we will together interact with ISO X-ray interface. This is what you see first when you turn on the system. This is home interface. You can click on the home button on the upper left corner to come back here. And then you have two selections, examination or lock screen. First, we will registration a new patient by manually. Now you have to type the patient details. On ISO X3, you will work with the touch screen on your workstation. So by touching one of the fields, the virtual keyboard will appear, enable you to type in. Required field will mark with a little star in. Again, before I start the exam, I need to assign clinical protocol I want to perform. So here is the body icon, and you just choose the body part or click in the name of the body part. So my selection will change to light gray. When I click for the second time, the body part, it will change to orange, and on the protocol of the body part. In this example is the spine, appear in the list here, and with the plus symbol, I can add the protocol in the list of my clinical protocol I want to do it. Of course, I can add additional protocol when I'm in the examination mode. After we click on the Start Exam, the screen will change to examination mode. You can see here is mainly divided in three parts. In the left is all the protocol you need to do. You can edit here. In the middle, you can look over to your patient in the examination room through the 3D camera on the tube. In the right is the parameter, as well as some feature I will introduce you here. There are two functions that I already mentioned in the slide, is virtual collimator and auto thorax collimator. Here I already activate. Now with the support of our college, you can see my college is doing positioning patient. And once she have done the positioning, she can leave the room without collimation. And you see, as soon as she no longer in the camera view, the auto thorax collimator detect the thorax and the collimator accordingly, and also the tube align accordingly. You can double check the collimator in workstation, or if you need to modify the collimator, then you just need to using virtual collimator to do it on the workstation. And one of the topic is positioning guide, which is just one click, you can see it right here. We are delivering small pictures to show you how to do positioning patient and how to collimate for that examination. Now we come to viewing tab. After my exam, I can use viewing menu to pause processing my image. And here you can see different tools on different tabs on the right side. We will start with favorite tab. Here I can configure up to 8 functions which I use most. So the ordinary workflow will look like this, like on the real system. So actually in the reality of the ISO X3, with the touch of the two fingers, I can rotate, zoom, or move my image to optimize image. I insert the label from the favorite tool. I can add the free text and change the style of the text. And if necessary, I can change image flavor and image visualization tab count, which bring me different image effects and impress for this image. Ideally, the preferred flavor for clinical protocol is set 1 to guarantee the constant image impress for all clinical protocol. And that is a short introducing some function on ISO X3. You can do in a chest examination. The final step after you have the image that you send it to the back. And here I want to introduce a AI-RAD companion chest X-ray. Artificial intelligence augmented workflow automation helps you to reduce the burden of basic repetitive tasks and increase the value of clinical outcome and precision. AI-RAD Companion Chest X-ray is a post-processing software which identifies and highlights the pre-specific radiographic findings using AI algorithms, and it is cloud-based platform that will support a wide variety of image interpretation, tools, and workflow. I understand that chest X-ray is being very routine in your workday. You meet it a lot every day, just like you brush your teeth after you wake up. You do it every day, but it doesn't mean that you always do it in the right way. So the ending message here that please don't underestimate the task the chest X-ray. Yes, it looks easy, but to a great quality of chest radiograph upon skill of radiographer, equipment condition, and cooperation of patients, this always challenging us. So after you finish your task, please go back to the patient and guide them to the next step.
All right, Mr. Hajime. I do not have very good news looking at the results. The blood test result came back positive for possible coronary artery disease, and the chest x ray shows an enlarged cardiac shadow.
What should we do, doctor, now?
Well, there are several advanced imaging procedures that we can do to confirm this diagnosis, each with its own advantage. Each procedure will give us unique information that could also tell us the severity of your condition.
Do I have to do all of them, doctor? I'm actually quite scared of needle.
Of course not. Would you like to see what the procedures are and how it is performed?
Yes, please.
All right, let's take a look at our first imaging option.
Good morning, everyone. So before we start the session on CT cardiac, let me do a quick short introduction for myself. So my name is Bao Wei. I am the CT application specialist for Singapore. And before joining Siemens, I was a CT radiographer in a hospital for slightly over 10 years. So today we are actually going to share about some principles and techniques for performing CT cardiac angiogram for patients with high heart rate. So let's move on to the topic itself. Okay, so then we're going to start with a little bit of a background first. So when we talk about cardiac CT, the main thing that we are looking for is actually coronary artery disease. And that, we have to know, is actually one of the major causes of death around the world every year. And in 2020 alone, it's estimated that this disease is actually responsible for about 11.1 million deaths around the world. So why would we actually use the coronary CTA as our first line of investigation for CAD? Well, this is recommended as an initial test for diagnosing CAD in symptomatic patients. We are talking about patients who actually experience chest pain, for example, and in whom obstructive CAD cannot be excluded by clinical assessment alone. One example of such clinical assessment would be the ECG. It is also actually a fast and non-invasive modality when you compare it to the gold standard, which is the catheter angiography. Also, it has a lower radiation dose compared to catheter angiography. And last but not least, the images are actually high resolution, and this is good for visualization of the vascular anatomy, as well as the neighboring cardiac structural anatomy as well. So, as with all CT examinations, or rather any examinations, there will always be some contraindications that we might need to consider before we send the patient off for the examination itself. And so here are actually some of the contraindications to coronary CTA for patients. All right, so patients which have some of these pre-existing condition might be contraindicated to actually do a coronary CTA, or they might require some pre-medications prior to the examination itself. This would include poor renal function. So we know that for coronary CTA, we will be giving iodinated contrast, and this is actually excreted by the kidneys. So patients with poor renal function, we're talking about patients with poor EGFR below 60, we need to consider the risk versus the benefit of the examination. If the patient is actually within the range of 30 to 60 for the EGFR, usually we recommend for hydration prior and post examination. Below 30, then this usually has to be discussed with the clinicians to see whether the benefit actually outweighs the risk for administering the contrast for this examination. Patients with multiple known drug allergies are also a risk because they have a higher chance of getting an allergic reaction to the contrast. For this, usually these patients are pre-medicated with steroids such as prednisolone before coming in for the scan itself. Finally, we also have patients who might have asthma. This is a similar concept to multiple drug allergies. So asthmatic patients has a higher chance of getting an allergic reaction to the iodinated contrast that we administer during the examination. And so patients with asthma will also have to be similarly medicated with prednisolone prior to the examination. So fundamentals of high quality cardiac CT imaging. This is a unique challenge of motion, resolution, and dose. So what are we referring to in terms of this? Well, the heart is constantly pumping, so we always have motion, but we need to kind of freeze the image so that we can see the vessels itself. And then, of course, the vessels are tiny, so we need good resolution here. And of course, this involves radiation dose, and a cardiac study is usually a relatively high radiation dose study. So for breast cardiac imaging, we actually require fast temporal resolution and high spatial resolution so that we can actually see the coronary arteries in no motion, and also be able to see the lumen clearly. So let's move on now to discuss some of the challenges that we face when we are actually doing cardiac imaging with CT. One of these challenges would be temporal resolution. So before we move on to talk about what exactly is temporal resolution, let's see why this is so important when we are talking about temporal resolution in CT. So it is a really great challenge to actually image the coronary arteries due to their small size, their tortuous three-dimensional anatomy, as well as their fast motion. So we know that the heart is constantly pumping, and because of the pumping, the associated vessels, the arteries, will all have pulsatile motion, and so they are constantly moving. And we can see here that this is the movement of the velocity of the the three major arteries in our heart. All right, the RCA, the LAD, and the circumflex. And here we see specifically that the RCA actually moves at a way higher velocity or speed compared to the LAD and the circumflex arteries. So with the constant motion, then it is actually very important to be able to see the arteries in minimal motion for us to be able to visualize for any plaques and any stenosis. So what are some of the imaging requirements when we are talking about cardiac imaging on CT? Well, we need fast temporal resolution, and this is actually the based on the gantry rotation time. So the gantry rotation time must be fast enough to minimize the motion artifacts that will be caused due to the arterial motion. We need high spatial resolution where it must be sufficient to depict small and complex cardiac vascular anatomy. We need a fast continuous coverage where we have sufficient coverage in the z-axis to achieve a required volume within a reasonable time when the patient is actually holding the breath. We also need synchronization to the heartbeat. So the scanner must be able to synchronize the acquisition to the appropriate phase of the cardiac cycle to avoid or minimize any motion and any misregistration. So why is temporal resolution so important? Now we're going to look at the cardiac acquisition window here. In association with what we see here is the ECG as well as the blood volume curve, all right, which is what we're seeing here is actually for the left ventricle. And this actually gives us an indication of the changes in movement. And here we see correspondingly that the area that has minimal changes in motion are here towards the end-systolic phase, as well as here in the end-diastolic phase. So to further illustrate the point about the acquisition window, we look now at two different heart rates, for example, here. So the first one is a nice low heart rate of 60. All right, so at low heart rates like this, the motion-free interval, the diastolic phase is actually quite long. It's about 258 milliseconds in this example, and this period is actually sufficient to acquire motion-free images of the heart, even if your scanner has a slightly lower temporal resolution. For example, on our single source where we have 150 milliseconds on the definition AS. So the diastolic phase of the cardiac cycle is actually dependent on the heart rate, while the systolic phase actually remains pretty stable, independent of the changes in heart rate. So at higher heart rate, here we see in the example 80 beats per minute, the motion-free interval is actually not wide enough. So we can see here on this example that this is actually only about 19 milliseconds. And so this is not wide enough interval for us to actually catch the heart motion, especially for systems with lower temporal resolution. So now then we look at the scanner possibilities. So as we would all know, temporal resolution is actually the rotation time of your gantry divided by 2. All right, so here on a single source scanner, the fastest temporal resolution that we can go to is actually somewhere around 125 milliseconds to 165 milliseconds. And so keeping in mind what has been mentioned in the previous slide, we are only able to acquire images in the diastolic phase, and if the patient has a higher heart rate, then it's not ideal for us to image the patient using a single source scanner. So this is where the dual source scanner comes into play. So with a dual source scanner, what is unique is that we actually have 2 tubes and 2 detectors, and so the rotation time, of course, on the dual source scanner is faster than that of the single source scanner. That's one. Secondly, because we have 2 tubes now, the time it takes to actually achieve half that rotation, where we have the temporal resolution at 180 degrees, is actually now faster because now we have 2 tubes to move together in motion, and so the temporal resolution is reduced down to 66 milliseconds to 75 milliseconds, and this is way faster than a single source scanner. And therefore, there are more possibilities that we can use for imaging the heart in terms of heart rate when we are looking at a dual source scanner compared to the single source scanner. So to reiterate the point earlier on our earlier slides, single source scanners has a limitation in temporal resolution. So the example here is a single source scanner with 150 milliseconds temporal resolution, and this is definitely above the 100 milliseconds temporal window for end systolic phase, and therefore a single source scanner will not be able to actually image in end systolic phase. However, this is a different story with the dual source scanner. The example used here is actually for a somatome force scanner, which has a temporal resolution of 66 milliseconds. So with the dual source scanner, this temporal resolution is below the 100 milliseconds window that we require for the end systolic phase, and therefore we can actually fit this into the end systolic phase and provide acceptable systolic reconstruction of the heart and the vessels at any heart rate. So now that we have looked at how temporal resolution affects the kind of scans where we want to reconstruct at which cardiac phase, we now look at the scan modes that we used in cardiac scanning. So when we talk about scan modes, then we're actually talking about the types of ECG triggering as well. So there are actually two types of ECG triggering that we actually will look at: prospective ECG triggering and retrospective ECG triggering. So we first talk about retrospective ECG triggering or gating. In this case, they actually switchable terminologies here. So here, this is actually also known as cardiac spiral CT. This is actually the traditional way when before we actually started doing CT scans and prospective ECG triggering. So the data acquisition actually is continuous as the table moves and there's a constant pitch. The ECG and the CT raw data are actually recorded simultaneously throughout the entire cardiac cycle. And this actually, the good point about using this is actually that we actually have a very, very high flexibility for data reconstruction. We are able to also edit the ECG when we are using this mode. However, because the radiation is continuously on during the scan, the dose is actually high to the patient. So we then move on to the next scan mode, which is the prospective ECG gating. All right, so essentially prospective ECG gating or triggering is a step and shoot acquisition of the axial slices at predefined time offset relative to the R waves of the ECG. All right, so this is the R waves of the ECG, and here we're actually basically telling the system when to turn on the radiation and scan at the specific position of the ECG itself. So reconstruction is actually done prospectively based on the timestamps from the recorded ECG. There are three different scan modes in cardiac here on our Siemens scanners that we can use with prospective triggering. All right, so there is the classic cardio sequence, adaptive cardio sequence, as well as the flash spiral. So just one thing to note that flash spiral is actually a specific mode that we can only use on dual source CT scanner. This is not available on single source scanner. So with prospective ECG gating, you can therefore see compared to retrospective triggering that we actually potentially have a lower radiation dose to the patient since radiation is not turned on all the time. So we're going to look specifically at the adaptive cardiac sequence scan mode and why we want to use it. All right, so it's actually able to detect irregular heartbeats. Right, we're talking about ectopic here sometimes, and therefore it can repeat scan at certain table position if necessary. It also allows for more than one phase of the heart cycle to be scanned. This means that I could actually potentially open up the pulsing range from 30% to 70% if the clinician desires to do so. So the scan start is actually determined prospectively based on the last 3 heart cycles, and scan is omitted whenever there's an extra systole that is detected right before the scan, and then the system is also able to repeat the scan in that table position if the extrasystole occurs during or shortly after the scan. So then, looking back now at the case that we had earlier in our scenario, we are going to scan the patient, and how would I do? What would I do for a patient in such condition? So we are going to start with patient preparation, which is really one of the most important things that you would want to do before we actually put the patient onto the scanner. So first, let's have a little recap on the patient, the history of the patient, and the indication. So we have Mr. Hajime, who is actually a 62-year-old male. He has actually got non-cardiovascular risk factors, being a smoker, hypertensive, diabetic, hyperlipidemia, as well as obesity. And he has actually come to see the doctor with current symptoms of shortness of breath and chest pain on exertion. And therefore, we're actually trying to exclude CAD when we are performing this coronary CTA for the patient. So, on arrival at the CT scan room, some of the basic things that needs to be checked would be Mr. Hajime's baseline heart rate, as well as any prior medical history. All right, so if you remember at the beginning of the presentation, I did mention about some contraindications and any requirement for pre-medications to a contrasted CT scan. So here we see that Mr. Hajime is actually diabetic. So we have to check whether he's on any metformin medication for his diabetes. And if he is actually taking them, we have to make sure that he has not taken it 48 hours prior to the CT examination. So for Mr. Hajime, his renal function is normal. He does not have a history of asthma or any known drug allergies which require pre-medications. His baseline heart rate was 90 beats per minute, and that's actually a variability of 70 beats per minute to 109 beats per minute. He was not given any beta blocker. So beta blocker is actually used to try to control a patient's heart rate. In some centers, the cardiologist gives beta blocker to the patient and instruct them to take it before coming in for the cardiac CT itself. And in others, they don't. So that's why it's very important to know whether they have already taken the beta blocker and decide what to do next. So after we have done all the baseline assessments and checks on the checklist, what should we do next? So usually after we know the patient's baseline heart rate, we report this to the reporting doctor, who would then decide whether we actually want to give beta blocker to the patient. As mentioned in the previous slide, beta blocker would be used to control the patient's heart rate to try to bring the heart rate down and stabilize them. So once this is prescribed and taken by the patient, we actually need to recheck the patient heart rate after a stipulated time to see if there's any changes. So most of the time, there is a specific dosage that will be given that's being decided by the doctor. And after the check, if the doctor decides not to further medicate the patient, then we will proceed to set the line for the patient for the scan. And the requirement for the line would be a 18-gauge IV cannula, a large bore cannula, because for the scan, we're going to give a high rate injection. So for Mr. Hajime, he had a beta blocker that was taken. Unfortunately, it did not control his heart rate. It was still high and slightly irregular. So then, in such case, what kind of scan protocol should we use? So in an earlier slide, I did mention about how the heart rate actually affects the acquisition window. So here in this table, we can see that as the heart rate increases, the RR length or interval actually decreases. And so basically when the heart rate increases, the diastolic window becomes almost non-existent, so we can no longer acquire the images in a diastolic acquisition window when the heart rate is high. So for heart rate around 80 to 85 beats per minute, it's challenging to acquire good images in diastolic phase on a single source scanner due to the temporal resolution limitations. And for heart rate above 85, it is impossible to acquire good images in diastolic phase due to the diminished diastasis phase. Acquisition in the systolic phase may then be used, and this would actually require very short physical temporal resolution, and this is only possible with a dual source CT. So then we have to make some considerations in our examination based on the patient's heart rate. So as mentioned in the previous slide, right, variances in the heart rate will actually influence our acquisition window. So patients with high heart rate variability, we are talking about more than 10 beats per minute, standard settings can result in high radiation dose to the patient. So we also need to know that since remember the table in the earlier slide, that end diastolic reconstruction will very likely be non-diagnostic. Therefore, it will be pointless if we open up the pulsing window to include the diastolic window. And so in this case, we will actually have to adapt the acquisition and reconstruction parameters for the patient's heart rate. So in Mr. Hajime's case, there are two scan modes that we can consider to use. All right, either the retrospective spiral scan mode or the active sequence scan mode. So taking Mr. Hajime's heart rate into consideration as well as our radiation concerns, the mode that we are going to choose today would be adaptive cardiac sequence. So a typical protocol for adaptive cardiac sequence would look like this. All right, so we will first perform a topogram and then do a calcium score. And for the contrast, we are going to use a test bolus to calculate the timing that we'll use for the actual cardiac CT itself. So now let's look at the trigger tab of the scanner for this case here. So because this is high heart rate, we are not going to get anything diagnostic in the diastolic window. So for the calcium score, I've actually set it to milliseconds and also to be in the time frame is where the end systole should be around. All right, so I'm aiming actually at the downward slope of the T wave. All right, so this is roughly where we would expect the end systole to be. The calcium score would be used as a base for planning for the coverage of the actual angiogram itself. And so for the actual angiogram itself, we've also set this to milliseconds acquisition and only aimed for the systolic window for the acquisition itself. So why are we using this protocol? Well, so the adaptive sequence with acquisition in the systolic phase is actually used, if you notice, with absolute delay times. All right, so this is because the length of the systole is actually a relatively fixed phenomenon. In patients with high heart rates or arrhythmia, systolic reconstruction phases perform better than diastolic phases, as we've mentioned earlier. Prospectively triggering the data acquisition using a absolute timing delay after the R wave would be done. All right, so in this case, usually it's about 250 to 400 milliseconds that we are usually going to use for the acquisition itself. Okay, so once the calcium score has been performed, then we want to start giving the injection of the contrast for the angiogram itself. But before we start to do that, we actually want to do a test bolus first. All right, so of course, some centers prefer to use contrast bolus tracking, but here in this example we'll be using test bolus. So usually for the test bolus, I would plan it at the same level as the first cut of my CTA. The injection rate would be the same as that on the actual scan. So the contrast volume for this test bolus should last for 2 seconds, regardless of what's your flow rate, and with a saline chaser at the same rate with a volume of 50 mils. So the scan for the test bolus would be performed until we see the contrast washed out, and then we terminate the scan. So we usually need at least 4 scans for that. And then these acquired images can then be loaded into the Dyna EVA for timing calculation. Okay, so then this is the example of how we would see test bolus images in the Dyne-Eva, which is used to evaluate and calculate the timing that we need to start the actual scan. So once the images are loaded, the first thing we want to make sure is that we actually enter the correct delay from start of the injection, which is usually the length of the breathing instruction, which is roughly about 10 seconds. And we draw an ROI in the ascending aorta, and then we get the results here in the lower quadrant. All right, so this is the time to peak that we have. And then the other thing that we want to look at is the peak HU, which tells us whether the injection rate that we have set for the patient is actually sufficient. So once we see that it's usually like above 100 pounds per unit, this means that the injection rate should be sufficient. And then we're happy to go ahead using the time that we have calculated here.
So once the time to peak has been calculated, then we want to set the time delay for the actual coronary angiogram itself. For adaptive cardio sequence or spiral mode, this would actually be the time to peak plus 2 seconds. Reason being that the amount of contrast that we're going to use for the actual scan is actually more than what we have used for the test bolus itself. So then we actually have to take into consideration that there is this increase in contrast volume, and therefore we are adding this 2 seconds to this time to peak calculated to account for this difference in the contrast volume.
All right, so then after we have calculated the time to peak and added the 2 seconds, which will give us 18 plus 2, 20 seconds, we enter this into the delay here so that we are telling the scanner when we are going to start the scan, when we trigger off the scan. And then for the contrast flow rate, we usually set it at the same rate as the test bolus. In terms of volume, we want to try and match back to the timing of the delay. So if this was a 5 mil per second, then I would be giving 15 mils of contrast and 15 mils of saline, both at the rate of 5 mils per second. All right, then the breathing instruction itself, we will be using a long breath hold instruction. Breathe in, breathe out, breathe in, and hold. In this case, since it's a long instruction and we are going to repeat this a couple of times during the scan, during the practice itself, we actually have to practice with the patient and also remind the patient that the depth of breathing in and out should be constant throughout the entire scan. So once all this is done, then we can click on the load button and start the scan. And so once the scan is done, we move on from acquiring the scan to the image reconstruction itself. So in this case, we are going to look at some of the parameters that we'll use for image reconstruction, specifically for high heart rate. So when we are doing the image reconstruction for cardiac post-acquisition, the scanner itself has a feature called cardiac best phase. It's used in image reconstruction post-acquisition to choose appropriate heart phase with minimal heart motion. The determined best phase represents optimal image quality in either the systolic or diastolic phase, and the system will automatically determine the phase start. So in cardiac best phase, there's two ways, two units that we can use for the reconstruction. The first one that we're looking at here is relative or percentage phase. So why we are saying a percentage phase is relative is because we are using the RR interval as 100%, and this changes based on the length of the R interval when the heart rate changes. All right, so we're actually giving it as a certain percentage of the R interval, and so the position will vary when there's a change in the RR interval. This is what we will usually use for image reconstruction in most cases where the heart rate is stable and low. So in the previous slide, we mentioned that percentage phase reconstruction is actually relative, and it's usually used for low stable heart rate. So in the case where the patient has a high heart rate, unstable irregular heart rate, then because the position of the percentage in the diastole would be different depending on the RR interval, then we need to consider using milliseconds instead for the reconstruction. So we are using this because it's actually a fixed constant delay time position after the R peak, and then we are using this to determine the start of the image reconstruction. So this position is usually fixed, all right, and not influenced by any change in the RR interval. And we usually use it in the end systolic phase, which is less sensitive to the RR variability and arrhythmia as compared to the diastolic phase. All right, then we need to consider what kind of slice thickness we want to use and the type of kernel. So generally, we reconstruct in 0.75 mm slice thickness with a 0.4 mm increment using a soft vascular kernel. All right. Some centers prefer to go down further to a thinner slice of 0.6 mm with a 0.3 mm increment, similarly with a soft vascular kernel. So the difference between these two, if you ask me, is actually in terms of image noise. So if you have a huge patient, a large patient, I would say I'll prefer to use a 0.75 mm reconstruction to reduce the image noise for the patient. So then there are also patients with stents or severely calcified coronary arteries. And so in these cases, during the scan itself, consider using semi-care kV and fixing the kV at 120 kV to reduce the potential beam hardening from the stent or calcified plaque. All right, so it should use the same slice thickness and increment as the above, but in case instead of using a soft vascular kernel, we'll have to use a sharp kernel to reduce the blooming artifact and improve the stent resolution and visualization. Okay, with that, we are ready to send the images off to be post-processed and be read by the radiologist. Thank you for your attention, and we will move on next to look at some simple post-processing on the single via. All right, so once we have done the scan, of course, we want to do some post-processing. So we are doing it on the single via. So here, I've already assigned images to CT coronary and calcium workflow. So the moment we open up, we are going to first get to the calcium scoring step. In this particular version, the system actually already has automatically marked the calcium in the vessels. So here we already have a preliminary Augustin score here. So we know that it's in the LAD. Let's have a quick look through. Here we see the first lesion that's marked, and then the second, and then unmarked one. No worries, we can just mark it. The table will be updated for the score. And then let's continue to have a quick look through. All right, and then so there's no more calcium that needs to be marked. So then we're happy to go on to the next step. The table itself with the score and a percentile chart can be sent off for documentation later when we finish and complete the entire workflow. So let's move on to the next step, which is CT coronary, which is where we will be looking at the angiogram images itself. So by default, the images are already displayed in all three planes, and the vessel center lines has been traced. The display is in MPR. If you prefer to look at it in mid-plane, we can actually change it to mid-plane in the segments. Here, of course, the center line that's traced is the RCA in profile, and then so we have a corresponding curved planar reformat of the RCA here that we can rotate around to have a look at the vessel itself. It has a corresponding cross-section of the vessel as well. If you want to edit center line, just click on control point edit, and here we just want to make sure and adjust to make sure that the points actually in the center of the lumen. If they are not, we can always just adjust it. Once we're happy, we can turn it off again. And of course, then we can move on to document a rotation around the vessel using a CPR, radial CPR range here. So the number of images is defined by the degree steps. Here I'm using 30 degrees, turning on high resolution. Once I click on start, a rotated image around the vessel is created. Again, this can be later exported off and sent off to PACS. navigate to the next vessel, I simply just click on the label here. So I'm looking at the LAD now, which then is rotated into profile here on the VRT as well. So here, of course, we see that there is this area of interest, which is actually where we see a narrowing. We want to do a measurement on it. You can simply just activate the tool here, stenosis measurement. All right, and here I'm actually using two reference points, green proximal to the point of interest and red distal to a point of interest. So then the system do give me two values for the percentage stenosis as measured in area as well as diameter. To document this, simply do a create finding. And the system would do a screenshot of the vessel with the stenosis along with the measured values that we have performed earlier. In the case where we're actually going to do stent deployment, we can also do a measurement of the vessel length to know the distance, the length of the stent to deploy for the proximal and distal to the stenosis. So by using the vessel length tool, we are able to also again create a finding and then be saved and sent off for documentation on the PACS later. On the VRT itself, we can also do radial ranges to do a horizontal and vertical rotation of the image. So usually we start off with doing a horizontal rotation first around. Click on start. It will give us a preview and then we can save this and then switch the axis to vertical, then do a vertical rotation as well. And again, save it. Okay, so these are just some of the simple basic processing that can be done on single via after we have acquired a coronary CT angiogram. So once we are happy with what we have done, we can either pause if you are not finished or simply just complete and save and send it off to PACS for documentation.
Ladies and gentlemen, I hope you enjoyed the session. We will take a short break for now. Please be back in 15 minutes for us to continue with our next session with Dr. Serena and Mr. Hajime.
back, ladies and gentlemen. In the previous session, Bawe showed us how CT coronary angiogram can assist the doctor in evaluating obstructive coronary artery disease. However, anatomy visualization alone may not be sufficient for us to come up with the best treatment plan. One or two complementary procedures may be required to obtain more information before a decision is made. Let's have a look at the next procedure Mr. Hajime is about to undergo and how it is clinically useful in his situation.
Hello everyone, I'm Yus Hafizal, MR application specialist from Siemens Sardinia, Malaysia. Following up with the previous scenario, let us help Mr. Hajime with the next common modality for cardiology examination. Without further ado, let's dive in our topic today, cardiac MRI viability study. Since like Mr. Hajime is not yet here, let's review what is the necessary information for patient preparation. There is no specific preparation instructions, and we always need to inform patients to proceed like their daily routine activities. We always advise patients to take daily medication unless instructed otherwise. A general preparation will be advised to patients, such as refrain from using lotions or oil on the chest area, and of course for male patients, do advise them to shave their chest. This is to ensure we had better electrode contact to the patient's skin. Nonetheless, please also encourage patients to arrive at least half an hour earlier. At the MRI suite, I'm sure we always had this kind of conversation with your patient in order to gain their cooperation and also ensure patient is well ready to undergo the MRI examinations. Good morning, Mr. Hajime. I will be your radiographer today. You may call me Yus. Before we proceed with the exam, I will need to start the MR safety checklist to ensure you are safe to undergo MRI scan. Then, I will briefly explain the procedure, the do's and don'ts, and what to expect. Let's begin. Ladies and gentlemen, this is the example of patient safety checklist. In the normal checklist, it should cover details as below. Whether the patient had any pacemaker device, any artificial heart valve, any prior surgery to patients, any history of shrapnel or metal that has gone into patient body. It will be best to briefly check with patients so that patient conditions are met for MRI scanning, such as if there is any chance of patients being pregnant for the female patients, if the patient suffer from claustrophobia, if patients suffer from asthma or COPD and require inhalers, and last but not least, do patients have any kidney problems. I do believe this standard checklist being used widely in your department. It is necessary to gather all this information and keep it in patient folder for further records. Dear my attentive fellows, before we go any further, I would like to emphasize here that the most common indication for CMR. It can be used for assessment of myocardial function following myocardial infarction. CMR also being used widely for assessment of myocardial viability or hibernation, myocarditis, cardiomyopathies, congenital heart disease, valvular disease, pericardial disease, and of course, myocardial tumor. Of course, just now I mentioned about common indication, but how about things we might need to consider before we put in patient inside MRI? On this list is not a mandatory contraindication, but we rather need to handle this with utmost precautions. We need to ensure do patient have metal implants, pacemaker, and prosthetic heart valve, any claustrophobic experience, and also the patient have any allergy reaction to contrast media priorly. I know this is also will be documented in our previous checklist, but like I said, this is not a mandatory contraindication. In example, the MR compatible pacemaker. With current new protocol, system is able to imaging in selected cases. And lastly, of course, we need to know our table limitation for patient weight. Okay, let's get back to Hajime. Mr. Hajime, we have gone through all the checklists and you are fit to undergo the MRI exam. Let's get going. Of course, the next step is to ask Hajime to change to our hospital gown. While hygiene may getting changed to patient gown and to be set with IV lines, let's review equipment that we are going to use. Normally, the equipment that we use and need are ECG electrode, body matrix coil, breathing bellows, unless your system comes with the built-in respiratory sensor, such as in our latest biometric system from Siemens, headphones, and call bell. In this slide, I would also like to emphasize the placing of our ECG for both new and old version of system. On the old version, you might need to use the technique like the top images. And of course, for the new system, you will need to place the ECG according to the lower bottom picture. We need to ensure a very good ECG tracing like in these top images. So how can we define a good electrocardiogram? A good ECG will show us sharp R wave that is higher than T wave while outside the bore, R wave higher than distortion induced by the magnetic environment while inside the bore, small baseline distortion, which sometimes can be due to patient respiration pattern and also electrode contact. The tips here is to ensure if we are handling male patient, we need to ask patients to shave their chest area. And for both male and female patient, I will always encourage the radiographer to do skin cleansing using the Nuprep gel. Nevertheless, a simulation of breathing instruction is a good practice in order to understand which instruction works better to your patient. With this, we will be able to ensure patient can follow the instructions properly during the exam. After we have a good ECG tracing, we shall ensure patient is comfort enough to cooperate with us. We secure the body matrix coil and ensure patient not to move during the exam. And then, let's move him into tunnel and review the scan technique. Normally, when we talk about scan technique in cardiac MR, this is the main topic to be considered. I will briefly bring your attention to morphology, cine, and delay enhancement sequencing. We will also introduce to you guys the new edition from Siemens. Let's start to look for each topic with the consideration of the reason and where shall we get the sequence from. First topic is morphology. The objective of this sequence is to visualize anatomy and characterize tissue of cardiac muscle and surrounding vessels. In cardiac MR, we will use turbo spin echo technique with possibility of producing T1 and T2 weighted contrast, including fat saturation, which is often helpful for the doctor to make their diagnosis. Here, we can find the sequence tree and do take note, all the sequence will come with dark blood preparation in order to give better visualization with the blood nulling effect. Secondly, the cine sequence. It will provide us the information of wall motion, which we can use to find any abnormalities, and the function of patient heart valve. With this information, cardiac MR allow us to evaluate the quantitative parameters of cardiac function. In the example, ejection fraction, LV mass, and many more. Here you may see where we can get the sequence from. You may find the sequence under function, and most common sequence used is cine trophy. Ladies and gentlemen, in this next slide, we will discuss on delay enhancement sequence. This sequence will show us an interesting phenomenon, which involving the equilibrium phase after we inject patient with contrast media. Infarcted region will be bright due to shorter T1 compared to a normal myocardium. Here, you may see the TI scout sequence and also common LEDGAT sequence 3 based on turboflash sequence. Nonetheless, 3 techniques involved in the delay enhancements. 1. Early GAT. 2. TI scout. And of course the last one, LEDGAT. Now that you are already understand the objective of cardiac MR and sequence selection, let's see how we can produce a good cardiac planning. In Siemens, we have at least 3 popular techniques to do the planning. Pseudo planning, 3D planning, auto planning with guidance. Let me briefly show to you guys. The first one is known as pseudo-planning. Using this technique, radiographer need to acquire the dedicated localizer like in this sequence tree. In order to get the pseudo to chamber, we shall ensure the planning line is parallel with the patient septum. You need to use transverse localizer like in these images. Plan the two-chamber localizer on the axial plane and angle the position line parallel to the interventricular septum. Move the position line to the center of the left ventricle, parallel to the line along the center of the mitral valve and left ventricular apex. In most patients, these structures are not seen in the same image, so scroll through the axial images to spot both structures. Secondly, once you had pseudo two-chamber, you can start to plan for short axis. Plan the short axis localizer on the two-chamber localizer and angle the position line perpendicular to the line along the center of mitral valve and left ventricular apex. In other words, ensure it is perpendicular to long axis of left ventricle. With this planning, you will be able to get the pseudo short axis view. Given that we already have pseudo two-chamber and pseudo short axis, now you are able to plan for your pseudo four-chamber. Plan the four-chamber localizer on the two-chamber localizer and angle the position line parallel to the line along the center of the mitral valve and left ventricular apex. Check the position in these two planes. An appropriate angle must be given in the short axis localizer. This is to ensure it is parallel to the line along the right ventricular apex and anterolateral papillary muscle. While planning in the short axis view, please scroll and try to avoid the aorta accordingly in order to get a good pseudo four-chamber. Next, we can plan the pseudo three-chamber localizer. Using the short axis localizer, please angle the position line parallel to the line along the center of the aortic valve and left ventricle. Ensure it is perpendicular to the posterolateral left ventricle wall. Check the position in the pseudo four-chamber also. An appropriate angle must be given in the four-chamber localizer, which is parallel to the line along the center of the mitral valve and left ventricular apex. Lastly, using the pseudo three-chamber view, we now can plan the line to parallel to where the aorta and left ventricle meet and prescribe a plane that passes through both of them. This will result in an oblique coronal scalp of the ascending aorta and gives up the left ventricle outflow tract. That is about pseudo planning. Of course, it takes more steps and usually radiographers always need to repeat in order to get better or true cardiac planning once they have proper cine images. Radiographers always need to be more particular while using this technique. The second technique is using 3D planning. In the interest of time, I would like to encourage you all to check this link for better explanation. This is credit to Mr. Julian Gunn, one of the senior application specialists in Singapore, which prepared us this interesting topic and technique, including the step-by-step. You may find this information on the Magneton Flash, Volume 72. Tips that I would like to add here is with this technique, we first need to run the no-gap single shot trophy sequence. You may find this sequence from here. Last but not least, in Siemens Healthineer, we always recommend this technique for a young radiographer and high-paced cardiac center. With Siemens' unique cardiac engine, user can get auto planning with very minimal user interaction on the system. Let's have a look at this interesting video.
The Cardiac Dot Engine provides many automation functionalities to help you with imaging the heart in MR. These include defining the maximum breath hold time for that patient, the language for auto voice commands, and the dot strategy. The ISO center localizer places the heart in the center of the magnetic field. You can get instructions and information in the guidance card to ensure the correct positioning is performed. You can use the auto-align heart to define the measurement orientations of the heart. This will be the basis for all the cardiac plane automatic positioning throughout the examination. From the 5 anatomical points defined in the auto-align heart, the long axis planes are automatically planned. Editing is possible, and the positions of the long axis slices will be used when needed for the entire examination. As in the long axis planning, the short axis planes are defined in the Define SAX step. The number of slices required to cover the left ventricle is automatically planned. Editing is possible if more slices are required. Editing of the order of sequences is possible with simple drag and drop functionality. You can easily monitor exam progress via various visual cues, such as green highlighting and progress timer. Cardiac settings of an opened protocol can be adapted while you are scanning. Simply select the tick boxes of the orientations to be measured and use the quick access to the protocol parameters to update them when needed. You can see what is happening at any point of time. For example, a green protocol is currently running.
The cardiac engine harnesses our unique standardization and automation technology to make cardiac scans faster and more robust. For those who would like to review this video again, you may do so by clicking the link given. Take note that the login information is needed to access the PEP Connect platform. Please be informed that this cardiac engine will require additional license. Ladies and gentlemen, as we had completed the cine imaging for Mr. Hajime, now let's proceed with the leg-gate enhancements. As per SCMR recommendations, we shall inject double dose contrast and then wait for 5 minutes delay. While waiting, let's have a look at inline VF result, another features that are coming with Siemens, and this is part of the additional software that Siemens have. Inline ventricular function is one of the functions that Siemens can offer to our customer. It can be activated for cine imaging and calculates left ventricular parameters based on a stack of short axis cine images. By activating it in a long axis cine, it takes into account mitral valve position additionally. With inline VF ventricular function, you can perform fully automatic volumetric assessment, ejection fraction calculation during the scan. The heart is located and the endo and epicardial borders are detected automatically. Data output is right after the image reconstructions without any user interaction. Key to remember, it is a very reliable and fast cardiac volumetric and ejection fraction assessment for a busy and high throughput oriented environment. It is also able to do automatic volumetric assessment and ejection fraction calculation even in patients with cardiomyopathy, dilated and hypertrophic heart, pericardial disease, cardiac tumor, and cardiac transplant. Attached inside this slide is a white paper comparing the inline VF function result versus the manual user contouring. Ladies and gentlemen, let's get back to Mr. Hajime. After contrast injection, it is encouraged to run early gate sequence. The objective of this sequence is to rule out any thrombus or tumor. The sequence needs to acquire within the first 2 minutes with the inversion time of 400 to 500 milliseconds. Normally, it will consist of long axis view only. Before we jump from early gate to late gate enhancements, I would like to emphasize the needs of TI scalp sequence. The contrast between tissue in an inversion recovery pulse sequence is strongly dependent on the TI value chosen. Selecting a TI value where a tissue passes through zero effectively nulls that tissue in the image, rendering it dark. To determine the proper inversion time, in order to null normal myocardium, an inversion time mapping sequence is frequently performed. This method is based on a principle developed by Luke and Locker used in the 1970s. When applied to modern MRI, it is known as TI scout. The technique consists of a centric ordered, segmented series of cine gradient echo, which will be obtained over 2 to 3 heartbeats, with each segment corresponding to a different TI value. The series of reconstructed images is visually evaluated to select the best TI for optimal myocardium nulling, and with that TI info, we will run the late enhancement sequence. Here you may get the TI scout sequence. The next technique of the scan, of course, delay enhancements. Due to the delay of contrast injection, during the equilibrium phase, an interesting phenomenon happens, so-called late enhancements will be occurs. Both normal and diseased myocardium will take up gadolinium contrast and exhibit enhancements. The rate of gadolinium accumulation and washout depends on multiple factors. This is including presence or type of heart disease, myocardial blood supply, heart rate, hematocrit, and renal function. Many diseases result in myocardial fibrosis with expansion of the extracellular compartment. In these delay phases, gadolinium washes out of a normal tissue but is retained by pathologic one. In myocardial infarction, for example, both uptake and washout are slow, so late enhancement is characteristic. This is sometimes called hyperenhancement. Do take note, late enhancement patterns do not only appear in the case of infarction, but also in a rather specific way in a variety of other cardiac diseases. Here you may get the sequence, and commonly the technique is based on turbo flash sequence. Alright, now it is already 5 minutes. With the predetermined TI value from our previous TI scout, let's get back to Mr. Hajime. After the TI scout sequence, Mr. Hajime squeezed the call bell and told us that he is unable to hold the breath sufficiently for the lead cat. Is only 2 slides able to capture as above. In this exam, we are unable to deploy our standard high-res technique. So, shall we stop? Like I mentioned to you previously, delay enhancement sequence is rather important information for the doctor to do their diagnosis. Some people even say that this is where the money value in cardiac MR. Worry not. In Siemens, we still can offer you somewhere around. Instead of keep trying with the standard high-res sequence, we can manipulate and change our approach to single-shot IR through field technique. Using this sequence, we can achieve a good resolution images even for patients with no brave hold capability. This sequence also very stable and a good choice for the first coverage of whole heart. We also encourage to cover the interesting region, left ventricle in this case, with single shot technique, and please also run at least in 2 different orientations. This is where you might find the protocol. And as for Mr. Hajime, with this workaround, doctor decided that this is enough information on his delay enhancement sequence. Ladies and gentlemen, now we shall proceed on the post-processing and also result. Early on, we look at inline VF. But if the option is not available, we shall proceed with the next post-processing technique. In Siemens, our post-processing allows you to see immediate result when you open your case under the MR cardiac analysis. It will give us inside information of LV analysis result and qualitative delay enhancement result. Using this feature of MR cardiac analysis, you will get instant display of pre-processed auto-segmentation of left ventricle, which is based on price-winning algorithm. You may also get the automatic calculation of ventricular volume, ejection fraction, and myocardial mass. Automatic calculation of myocardial thickening for all myocardial segments following the AHA segmentation. Semi-automatic post-processing of the right ventricle. Dynamic evaluations such as time volume diagrams, filling rate, and myocardial wall motions. Integrated and synchronized movie display. Graphical display of results such as table, bullseye plot, 4D model of the heart, and integration of the result in a report for documentation. In summary, with MR cardiac analysis, especially for left ventricle, user will get auto-contouring with base plane correction on long axis within their finger. For further info on this, please visit the link given. Lastly, using the delay enhancements, doctor will be able to localize and determine the pathology area accordingly. With all of this information, it brings us to the last step, which we already completed, the viability study. It is the end of our examination. We must ensure patient is okay and all our images been sent to reporting doctor. We have completed the scan, Mr. Hajime. I will remove the IV line and get you changed. You may return to the clinic while we get your MRI report ready for your doctor. While the radiologist is reporting Mr. Hajime images, let's review new technique available from Siemens. We all know we had some challenges, especially in order to characterize and quantify tissue changes. With conventional delay enhancement, we still had difficulty to detect non-localized and diffuse tissue changes using only qualitative data. Building that in mind, we at Siemens Healthineers would like to introduce you with MyoMaps. Let's have a look at this short video. Please be informed, with MyoMaps, you will get on-the-fly quantitative maps without the need of any user interactions. MyoMaps will give us information in the shape of relaxation time mapping, which will broaden our possibility in characterize tissue changes. Another challenge is on leg gate enhancements. Previously, we introduced you the workaround of single-shot IR through his technique. Almost all the time, patients will suffer and complain that they are unable to follow the breathing instructions anymore. So end up, your images will be something like in this slide. Rest assured, with the latest Siemens technology, we can offer you a solution of heart freeze software. Heart freeze comes with motion compensation algorithm, which will bring the benefit in acquiring high-resolution images in a free breathing. And at the same time, hospitals are able to extend their cardiac MR services to even more patients. This is including pediatric and geriatric patients which cannot hold their breath. And of course, it's also advantage to the arrhythmia patient. For your information, the minimum level of your system software need to be on XA platform. Now, MR report is ready. Let's follow up with Mr. Hajime at Sarina's Clinic. Thank you for listening and good day. Sehingga berjumpa lagi dari Malaysia. Terima kasih.
The multiparametric nature of cardiac MRI can provide comprehensive assessment in patients with known or suspected coronary artery disease. Its ability to directly assess myopathies and its extent often contributes insights that can change the patient's management. Unfortunately, the lengthy duration of the procedure and the narrow design of the gantry make it challenging for some patients to tolerate the procedure. Also, those with metallic implants or pacemaker may not be suitable for cardiac MRI. CMR is complex. It is not a single technique. Instead, it consists of multiple distinct techniques, and a lack of understanding of which techniques to perform and how to interpret the findings limits its widespread use. For this, a different imaging modality may be considered. Let's see how molecular imaging can be used to further evaluate the extent of Mr. Hajime's condition and how it can be performed.
Hello everyone, my name is Adrian Luigi Morte, Clinical Application Specialist for CT and MI from the Philippines. Today, we will discuss one of the most important diagnostic tools in the assessment of coronary artery disease available in nuclear medicine. This is myocardial perfusion and viability. While other diagnostic imaging modalities offer structural and morphological information, molecular imaging provides functional images to assess coronary artery disease. It provides information on the extent and severity of myocardial perfusion abnormalities, including ischemia, left ventricle size and function, and mechanical dysynchrony. At the end of this learning activity, participants will be able to understand the role of molecular imaging in diagnosis of CAD, differentiate myocardial perfusion from viability, identify the different radiopharmaceuticals in nuclear cardiology, demonstrate scanning and reconstruction techniques, and finally, evaluate myocardial status based on scintigraphic images and patterns. Myocardial perfusion imaging. A diagnostic study used to evaluate myocardial perfusion and function to detect physiologic and anatomic abnormalities of the heart. It portrays images of blood flow to the heart muscles. This is done by first injecting a radiopharmaceutical. So the radiopharmaceutical will be administered to the patient intravenously, delivering the radiopharmaceutical to the systemic circulation, finally reaching or perfusing to the myocardium via the coronary arteries. So once delivered, a viable metabolically active myocardium must be present to extract the injected radiotracer or the radiopharmaceutical. Finally, using our diagnostic imaging modality in nuclear medicine, which is the gamma camera, scintigraphic images will map regional perfusion or blood flow. So as you can see here in the image, this is an image of the left ventricle myocardium that successfully extracted the radio tracer because of two primary reasons. Number one, because the coronary arteries is patent. And number two, because the heart muscle or the myocardium is viable enough to extract the radio tracer. However, if a patient has CAD or coronary artery disease or loss of cell viability as a result of infarction, a perfusion defect or cold spot or cold region is seen on the images. Referring again in this image, when a patient has CAD, some areas of the myocardium of the left ventricle will not receive the radio tracer or the radiopharmaceutical injected. Hence, this is again, we call it the cold spot. As for the indications, MPI scan will be ordered to patients to the following purposes. Number one, detection of obstructive CAD and define the number, location, and significance of coronary artery stenosis. Risk stratification of patients and to provide prognostic information. Assessment of myocardial viability. To provide guidance on medical therapy and monitoring of treatment effect after revascularization procedures. However, for some patients, this procedure is contraindicated. Number one, recent ingestion of contrast media. Number two, radionuclide study performed within 48 hours. Number three, patients with severe arrhythmia or irregular heartbeat. And finally, a patient who is pregnant or is lactating. Next is patient and scan preparation. Patient should fast for 4 hours. Patient should not consume any amounts of caffeine 24 hours prior to the procedure. Patient should not smoke 24 hours prior to the procedure. Upon approval of the referring physician, patient should discontinue medications. Example is beta blockers. Beta blockers may prevent the achievement of heart rate necessary for a successful stress test. Next is nitrates and calcium channel antagonists, which can possibly mask underlying ischemia. Lastly, patients should be well rested and avoid strenuous activities. Now, let me demonstrate a step-by-step guide on how to perform myocardial perfusion imaging scan. First step is administration of radiopharmaceutical. A radiopharmaceutical is a combination of two components. The first one is a radionuclide. A radionuclide emits gamma rays, which is necessary for image formation. The other component is the biologically active molecule or the pharmaceutical, which serves as the carrier. So let us have an example. For our radionuclide, we have technetium-99m. Technetium-99m is the most common radionuclide in nuclear medicine imaging. It has a half-life of 6 hours and an average energy of 140 kiloelectron volts. For our pharmaceutical, we take sestamib as our example. Sestamib, when injected into the patient, will always localize into the heart muscles or the myocardium. So altogether, we have technetium-99m and sestamib as our pharmaceutical. We call it technetium-99m sestamib. As mentioned earlier, this radiopharmaceutical shall be injected or administered intravenously to be able to deliver it to the myocardium. There are two major radiopharmaceutical for this procedure, myocardial perfusion imaging. These are technetium-99m sestamib, which is taken up by the myocardium according to regional myocardial perfusion. The adult dose is in the range of 15 to 30 MCI, and usually we administer it by 2 doses. The first dose is injected before the rest scan, and the rest scan will be performed, or the patient will wait for 45 minutes to 1 hour before the imaging. The next dose will be administered after a successful stress test. After a successful stress test, the patient will now be scanned in the gamma camera after 30 minutes. The next radiopharmaceutical is thallium-201 chloride. Aside from thallium-201 chloride as being a perfusion agent, it is also special in a sense that it can assess myocardial viability because of its property of redistribution. The adult dose is in the range of 74 to 148 megabecquerel or 2 to 4 MCI. And unlike with sestamib, we only give 1 dose of thallium-201 chloride to our patients. And this is usually given during a successful stress test. After a successful stress test, we will scan the patients within 15 minutes post-injection of thallium-201 chloride. And after 3 to 4 hours, we will commence with our rest scan. As preferred by the cardiologist, it may be necessary to perform a 24-hour delayed scan for certain purposes. The next step is to perform a stress test. So why is this necessary? By increasing cardiac work, the demand for oxygen and thus blood flow increases. In response, the coronary arteries vasodilates. If the patient has stenosis or coronary artery disease, vasodilation will be limited. As mentioned in the preceding slide, the radiopharmaceutical shall be administered, but only after a successful stress test, the radiopharmaceutical will be administered. So what do I mean by a successful stress test? The patient may run on the treadmill and must reach at least 85% of the age-predicted maximum predicted heart rate. So after this, after the achievement of this minimum requirement of 85%, the radiopharmaceutical can be administered intravenously. So a stress test procedure can be performed in 2 ways. Again, number 1 is physical. The patient may run on the treadmill. And again, the goal of the patient is to reach at least 85% of the maximum heart rate requirement. If for some reasons or for some conditions of the patient could not run on the treadmill, we can opt for a pharmacologic way of stress test. So in the pharmacologic way of stress test, we administer drugs that mimic vasodilation and increase heart rate. The first on our list is dipyridamole. Dipyridamole is infused by the following parameters: 0.14 milligram per kilogram per minute for about 4 minutes. So when infused, please note that aminophylline should be at hand to reverse significant side effects such as asthma, since dipyridamole is a vasodilator drug, which can also vasodilate the bronchi. If patients are asthmatic, it can worsen their condition. Next on our list is the butamine. The butamine is injected 5 to 10 millicentigram per kilogram per ml over 3-minute increments, rising to 5 to 10 millicentigram per step until the 85% of the maximum heart rate is reached. So this is like injecting a drug, and the patient will experience a significant increase in his or her heart rate. And when the patient reached at least 85% of the maximum heart rate, we can now administer the radiopharmaceutical. Last on our list is adenosine, which has an infusion rate of 0.14 milligram per kilogram per minute for about 6 minutes. So again, we can opt to use pharmacologic drugs or stressors which can mimic the vasodilation and also the increase in heart rate of the patient when the patient could not run in the treadmill. So how do we perform a stress test? To perform a stress test, the first step is to place the 10 electrodes on the patient's chest and hook the ECG monitor. Refer to the first image on the correct placement of the 10 electrodes in the patient's chest. Second step is to monitor the blood pressure in sitting and standing position. Third step is to start the treadmill using the modified Bruce protocol. Fourth step is to take blood pressure and ECG every 3 minutes of each stage of the modified Bruce protocol. Then inject the radiotracer at peak exercise. Again, this is the goal of the patient, to reach at least 85% of the max heart rate. Finally, let the patient recover and start the stress scan within 15 minutes. Following a successful stress test, and that we already administered our radiopharmaceutical, thallium-201 chloride, we can now perform our first scan. This is the stress scan. The stress scan will follow the following parameters in this protocol. First one is the collimator. So if we are using technetium 99M as our radionuclide, we need to install low energy, high resolution collimators. But since we administered thallium-201 chloride, we need to install low energy, all-purpose collimators. Next, the gamma camera heads will collect information from the patient's heart at a gated tomo acquisition. Gated meaning that the ECG are connected into the patient's chest to be able to collect information of the patient's heart free from motion. Each detector will be at a 90-degree configuration with one another, and the gamma camera heads will rotate towards the left side of the patient where the heart is at 180-degree angle. 40 seconds per view, and a total of 32 views will be collected from our patient. If CT is available, as with our hybrid scanner, SPECT CT, we can perform CT for the purposes of attenuation correction. But for example, if CT is unavailable, we can scan the patient in prone. So how do we perform the stress scan on our actual patient. So again, we need to configure our detector heads to be at 90 degrees with one another. Within 15 minutes, we position the patient supine in the scanning bed. We position the patient's arm over his head using this accessory. We put the electrodes on the patient's chest and hook the ECG to facilitate the gated acquisition. We move the bed towards the detectors, locate the heart, and position the detectors as close as possible to the patient. Of course, we instruct the patient to refrain from moving during scanning. And again, for reference, this is the correct position of the electrodes in the patient's chest. Then, we acquire and let the machine do its job, collecting 180-degree projection towards the left side of the patient. For our second and final scan, we perform the rest scan. We instruct our patient to return 3 to 4 hours post-injection of our radiopharmaceutical, which means that the heart at this state is well rested. So basically, this is the same procedure we performed in our stress scan procedure. Again, we position the patient supine in the scanning bed, arms over his head. We put electrodes to be able to facilitate gated tomo acquisition. And we move the bed towards the detector. Again, locate the heart, position the detectors as close as possible to the patient, and instruct the patient to refrain from moving. As mentioned in the previous slides, CT can be performed alongside with our myocardial perfusion imaging procedure. This is for the purposes of attenuation correction. The effects of soft tissue attenuation can be seen on most cardiac images and worse with large patients. For example, males have decreased activity in the inferior wall called diaphragmatic attenuation. Among females, relative decreased activity in the anterior wall, apex, and anterolateral portion secondary to breast attenuation. So for this scenario or instances, CT can be helpful in minimizing attenuation artifacts. Aside from this, CT can be used for coronary artery calcium scoring, and eventually we can also use CT for coronary artery angiography or CTA. This CTA data or images can be fused with our SPEC studies to be able to create an overlay of the anatomy and physiology of the heart muscle. So with CT, this gives us additional diagnostic information on the morphology of the coronary arteries, supplying blood to the myocardium. And again, for SPEC or in myocardial perfusion SPEC, in molecular imaging, which gives us functional data on how well the blood is perfused in the myocardium. So we have both anatomy and physiology as our data in this fusion. After successful acquisition and processing of our SPEC datasets from stress and rest images, I will now present the myocardium in its three-dimensional orientation. So this is a normal image of the myocardium performed under myocardial perfusion imaging. The first orientation is the short axis view, which divides the slices from apex to base of the heart. So the scintigraphic images looks like this. And as you can see, there is two data sets compared with one another. These are the stress and rest images. Next is the vertical long axis. So we divide the myocardium into left and right portions. So basically, this the scintigraphic images looks like this, wherein the apex is here and the base is in this side. The anterior portion and the inferior portion of the left ventricle myocardium. Finally, for our last view is the horizontal long axis, which divides the myocardium into superior and inferior portion. The scintigraphic images looks like this. So again, this is a normal myocardial perfusion imaging scan. For the image interpretation, again, we compare rest and stress datasets. That, for example, if a defect or a cold spot is seen in stress but not in rest, we can say that the myocardium is ischemic, or we refer this as myocardial ischemia. This is a reversible defect, which means the patient can benefit for a revascularization procedure. For example, a percutaneous coronary intervention. In another scenario that we see a defect or a cold spot in both stress and rest, the myocardium is said to be infarcted, or this is a dead muscle tissue, or what we know as myocardial infarction. This is an irreversible fixed defect, which means the patient will not benefit to a revascularization procedure. So in summary, in this table, again, only if we see a cold spot in stress, but the rest is normal, again, the term is ischemia. But if we see both cold spot in rest and stress, this is a myocardial infarction. Then previously, I showed you the three orientations of the myocardium when we performed our SPEC acquisition or gated TOMA acquisition. So again, here we have the short axis view of the heart, and labeled for each segment is the supplying coronary arteries involved. That, for example, in both the septal or an anterior portion of the myocardium, the left anterior descending artery supplies blood in this area. For the inferior portion of the myocardium, the right coronary artery supplies blood in this area. And in the lateral portion, the left circumflex artery supplies blood in this area. So what does this mean? So if, for example, we see a defect or a cold spot in the anterior portion of the myocardium, it means or it may mean that the coronary artery left anterior descending LAD is obstructed or there is stenosis in that area because there is no perfusion or cold spot seen in this region. So basically, we can have information on what coronary arteries is involved because of the cold spot or a defect seen in each portion. We can also cross-check this with other views, again with our horizontal long axis and vertical long axis images. And again, for your references, these are the LV walls and supply arteries for apical, septal, anterior, lateral, and inferior portion of the myocardium and their corresponding coronary arteries that is supplying blood to this area. So here in this slide is an example of a myocardial infarction, which matches a defect in both stress and rest image. So again, this is the short axis view of the heart, and the defect in stress, for example here, corresponds to the defect in rest here in this inferior portion. So we can diagnose that this is a myocardial infarction. Now that we have discussed myocardial perfusion imaging, in which we describe the myocardium as myocardial ischemia or a reversible defect. And patients with this condition can benefit from the revascularization procedure, such as percutaneous coronary intervention. On the other hand, we also describe the myocardium as being infarcted or myocardial infarction, which is an irreversible defect. And patients with this condition will not benefit from the revascularization procedure. Although this is the case, 20% of patients with these findings do not have infarction, but rather severe chronic ischemia or hibernating myocardium. So with this, we will now discuss the myocardial viability, which checks or gives an opportunity for our patients with myocardial infarction to be able to become a possible candidate for revascularization procedure, provided that their myocardium is still viable. Myocardial viability. Viability refers to the myocytes that have preserved cell membrane integrity and sufficient metabolic activity to maintain cellular viability, but not contractility. Patients with viable but hypoperfused myocardium can benefit from coronary revascularization. Again, an example is percutaneous coronary intervention. So for a patient to be subjected with this kind of procedure, a doctor may be ruling out a hibernating myocardium, a chronic ischemia with decreased blood flow and downregulation of contractility. And again, this is reversible with restoration of blood flow. As discussed earlier, thallium-201 chloride is one of the radiopharmaceuticals for myocardial perfusion imaging. Aside from this, thallium-201 chloride is used for the assessment of myocardial viability. In this regard, we will now discuss myocardial viability protocols available in our thallium-201 chloride radiopharmaceutical. The first one is thallium-201 late redistribution. Imaging beyond 3 hours for delayed redistribution. This is usually an additional scan 24 hours after the radiopharmaceutical administration. The rationale behind this is that severely ischemic myocardium with slow and uptake clearance requires more time to redistribute. The second protocol is a rest thallium-201 redistribution for patients with known coronary artery disease, prior myocardial infarction, and ventricular dysfunction. This justifies the need for a revascularization procedure. Rest 1 includes images obtained at 15 minutes, and Rest 2 includes images obtained after 3 to 4 hours. So, regardless of these two protocols, even if the patient has been diagnosed with myocardial infarction in their myocardial perfusion scan, provided that the thallium-201 myocardial viability is successful, they have the chance to benefit from our revascularization procedure. So for our demonstration, we selected the thallium-201 late redistribution protocol, in which, again, we have the stress, rest, and thallium-201 24-hour delayed scan. So to process these images, we select all of our data sets and click on the designated workflow to process these data sets. So in our data selector, we ensure that the workflow inputs contains the datasets stress, rest, and thallium-201 24-hour delayed. In the quality control, we check for any motion artifact. So if we found out motion artifact in any of these datasets, we can apply motion correction, or better, we rescan the patients. The next step is the auto-recon. So in the auto-recon, we apply reconstruction algorithm. We can apply either an OSEM 2D or a Flash 3D. And we ensure that each dataset is constrained in our ROI, or in that yellow region as you can see in the screen. We also check for the gated slices and images. Next, we click on the reconstruction tab. So same procedure, the yellow ROI must contain the myocardium. And for each orientation, HLA, VLA, and SA, the myocardium must be properly positioned. You can control the knobs at the bottom of the HLA and VLA to be able to orient the images correctly. And pay attention to the transverse angle. It should be the same for all images, as well as the sagittal angle. We also check for the gated if it is constrained in the ROI we selected. Next is masking and centering. So usually, when we process this, we usually start with the short axis view. So we perform a mask to be able to remove extracardiac uptake in our scan, because this will affect our results later. We also check the VLA and HLA and apply accordingly to all datasets we have. So we have the stress, the rest, and the thallium-201 24-hour delayed scan. Okay. And then also, you check for the gated slices. And you can also change the LUT to the preferred warm metal. And of course, you can apply zoom, display zoom whenever necessary. Then again, apply the masking and centering technique to be able to exclude extra cardiac uptake. Okay. So for the rest gated, we do the same. We zoom in and apply mask and centering. So again, starting with the SA and proceeding with the VLA and the HLA. Then finally, we will have the three data sets compared with one another. So we have the stress, the rest, and thallium 201 24-hour delayed scan. Each slices is matched accordingly to the correct slice position to be able to compare it accurately to the to one another. You also check for the VLA if the slices position are matched, and of course you do the same with your HLA. After processing and reconstruction, we can now submit the reconstructed images in our third-party cardiac applications. We can use Corridor for DM, CDARS, or Emory. For this demonstration, we will use the CDARS application. In the Singovia, we will now process our datasets using the CDARS application. Of course, we first select our patient and select the applicable datasets, rest, stress, and thallium 201 24-hour delayed series. We open this using our MI cardiology workflow, which automatically opens or loads our CDARS application. Once opened, we will ensure that this dataset is compared with a normal database limits, which is thallium. And then to ensure that the selection is applied, we click process. Starting from the raw tab, we check our images. Next is quality, which checks for motion artifact, if applicable. Then for the slices, we compare our three datasets, namely stress, rest, and 24-hour delayed scan. So we ensure that these are correctly selected. Let's turn off, for example, the left ventricle outline and check on each slices. So in the first slice, we see that there is a defect in the inferior wall of the myocardium. This is also seen in the inferior wall of the myocardium in the rest series. And surprisingly, in our 24-hour delayed scan, the defect seen in the inferior wall of both stress and rest is not depicted, which means that the inferior wall is viable, or we can say that this is a hibernating myocardium, which means this patient could benefit from the revascularization procedure. Okay. Next is surface, then splash for a slice by slice comparison of our three data sets. So again, we select the appropriate data sets, stress, rest, and 24-hour delayed. We unzoom as necessary. And then, of course, slice by slice, in the short axis, you see that there is a hold effect again in the stress and rest, which means that this is a case of myocardial infarction. However, we see uptake in the inferior wall, which means, again, this is a hibernating myocardium, or the myocardium is viable. We check on other slices, HLA and GLA, to be sure. And then we go to QPS, or quantitative perfusion spec, to check necessary values in our results. So important results include volume, wall, defect, extent, TPD, and as well as the shape. Of course, based on our qualitative inspection, of course, there is a defect already, but of course, the system gives us the numbers or the quantitative value for this, such that in the stress, the inferior wall has 15 points. And in the rest, it has 6 points, which garners a total perfusion defect of 1.1 and a reversibility of 10. Of course, we can apply segments and click on functions like severity and extent to be able to score appropriately on the area of the cold spot and the reversibility that is possible. Now we compare rest and the 24-hour delayed scan. Of course, in the rest, there is a cold spot, but in the 24-hour delayed scan again, this is viable, and applicable scores for each section. Next is quantitative gated spec, or QGS. So we select the applicable data set. For this one is the stress gated, wherein we have the TID, or the transient ischemic dilatation, the LHR, and or the lung heart ratio, and other pertinent scores in our perfusion. Of course, you have the volume, EDV, and diastolic volume, ESV, and systolic volume, stroke volume, and the ejection fraction. You can click on the gate tab to be able to see a scene of the myocardium during stress, and click on the graph to be able to see a graphical representation of the extent of defect in the stress and in the rest. Then finally, in the change tab, we see all of the our data sets in stress and rest. And there you have it. That's how you process myocardial perfusion and viability in the CDARS application. Maraming salamat po sa inyong pakikinig. Muli, ako si Adrian Luigi Morte from Siemens, Philippines.
Ladies and gentlemen, we have completed our morning session. It's time for a lunch break. We will resume the session in 1 hour's time. In the meantime, you may continue to send in your questions. We will collect these and address them during the panel discussion session at the end of today's presentation. Additionally, we would appreciate it if you can answer the following survey. Kindly scan the following QR code or click on the link in the chat pane to access the survey form. See you in 1 hour. Have a great lunch.
Perception, understanding, reasoning, creativity, wisdom, learning, intelligence, the ability to think abstractly and rationally and use that thought for purposeful action, the strongest tool of humankind. And a concept that we have pushed even further, making technology our strongest partner and giving us the confidence we need to make the right decisions intelligently. My exam companion is intelligence that works with you. It uses the new possibilities of digitalization to turn data into built-in expertise. To unlock the full potential of ECO Xpre. My exam companion helps users on their way to the consistent results that radiologists need. My exam companion, intelligence that works with you.
Fast temporal resolution, powered by dual source CT. Reducing the rotation time as much as possible to minimize motion artifacts is crucial for some patient groups. While single source scanners have gotten faster, physical rotation time restrictions mean that they can't cross the 100 milliseconds threshold. So, motion artifacts remain a problem. It's a completely different story with dual source CT, because the tubes can work together to help you speed up your scans. When you set each tube to perform only a quarter rotation, you still get a half rotation in total. This enables you to achieve resolutions even below 75 milliseconds. As a result, dual source CT is capable of eliminating motion artifacts, even during the most demanding applications. Fast temporal resolution, powered by dual source CT. Dual source CT, ready beyond tomorrow.
I was born with asthma. The best way I think to describe that would be it's like drowning from the inside. It's not being able to breathe out, and that's why people will die. Between being born and being about 9 or 10, I was hospitalised 24 times. It still affects me every day, and I have to take medicine every day. I think maybe being in hospital has made me a bit of a loner. So I think I found my niche in finding having mates as musicians. They're all very much like me, so we're all slightly geeky and a bit weird. I don't know why I can play the trumpet but can't do other things. It might just be practice. It means a lot. I absolutely love it. Teaching the trumpet is so different because they're getting it. And you can see that they were playing with them like they were toys. That's how it should be. It's fun. So if it's fun for them, it's fun for me. And that's it. And I don't think I'm any different to anyone else in that respect. Because I think everyone has got limits to what they can do. Just mine's a little bit more obvious, maybe. You're fortunate to have a life, so do something with it.
Consider the power of a single component. It can lead to a better image, an earlier diagnosis, a more effective treatment strategy, an improved outcome. Big changes start small. Only by focusing on the smallest of details can we create the greatest value over time. And no one understands this better than the people who design and build our PET and SPECT solutions at Siemens Molecular Imaging.
So at Siemens, people and technology come together in a very unique way. And a lot of that has to do with the fact that we own the entire value chain, making a better quality product for our customers, and that's going to help them serve patients every day.
It all adds up to more for our customers. We are the only molecular imaging company that owns every step of the process.
We grow our own crystals. The full chain of taking those crystals and integrating the crystal into the rest of the detector is something we design into this methodology, and we also make sure that we track the quality of that whole process.
Each individual crystal element is hand inspected, and the person who does this particular process handles millions of pixels every year.
The collimators we also design and build ourselves. The materials we use for that provide for consistency and uniformity of the field of view.
We also have an integrated engineering group that does all of our robotics automation, does all of our testing equipment. The purpose is to give us the advantage of having that ability to improve our quality, to manufacture the best detector that we can manufacture.
When every design decision is purposeful, every step of the process is impactful. This philosophy drives the research behind every piece of groundbreaking technology that we create.
We want to make sure that we provide a device that meets the needs of our customers and meets the needs of patients. We don't want to just put a technology out there that doesn't have true advantages to our customers.
The R&D function is complex. We actually have to generate the idea, cultivate it, then bring in the entire team, grow the idea, and bring it to production.
We're very clearly innovation leaders. We make sure that that innovation is focused on real deliverables for the clinical outcomes.
Making a difference means starting small. Day by day, image by image, person by person, we are advancing the field of molecular imaging to benefit everyone, the patient, the caregiver, and the healthcare provider.
Early detection really makes a difference in disease.
That technology, the better image quality, the higher resolution and sensitivity all adds up to great outcomes.
That's really our vision, to enable our customers by giving them reliable, sustainable technology for them to further grow molecular imaging for a much wider population than we're doing today.
Every day, you're giving your very best. We know that and are here to support. The number of obese and multi-morbid patients with coronary artery and vascular diseases is rising. Siemens Healthineers can help you to manage the growing workload, to utilize applications that may help improve clinical outcomes for all your patients, and to make confident diagnostic decisions fast, empowered by our integrated cardiovascular solutions. The perfect support with Siemens Healthineers.
Welcome to the next generation of Syngo Dynamics. Digitalization is changing healthcare today by transforming care delivery. Cardiology departments are being challenged by disparate data systems, decentralized work environments, and increasing amounts of data. The next generation of Syngo Dynamics is the latest centralized digital hub for the entire cardiovascular service line. It aggregates data and information across the enterprise to streamline imaging IT. With a new user interface and intuitive reading, data and images are quickly connected to improve clinical and operational workflows. For informed decisions and better patient care.
Perception, understanding, reasoning, creativity, wisdom, learning, intelligence, the ability to think abstractly and rationally and use that thought for purposeful action. The strongest tool of humankind. and a concept that we have pushed even further, making technology our strongest partner and giving us the confidence we need to make the right decisions intelligently. My Exam Companion is intelligence that works with you. It uses the new possibilities of digitalization to turn data into built-in expertise. To unlock the full potential of ECO Xpre. My Exam Companion helps users on their way to the consistent results that radiologists need. My Exam Companion. Intelligence that works with you.
Fast temporal resolution, powered by dual source CT. Reducing the rotation time as much as possible to minimize motion artifacts is crucial for some patient groups. While single source scanners have gotten faster, physical rotation time restrictions mean that they can't cross the 100 milliseconds threshold, so motion artifacts remain a problem. It's a completely different story with dual source CT, because the tubes can work together to help you speed up your scans. When you set each tube to perform only a quarter rotation, you still get a half rotation in total. This enables you to achieve resolutions even below 75 milliseconds. As a result, dual source CT is capable of eliminating motion artifacts, even during the most demanding applications. Fast temporal resolution, powered by dual source CT. Dual source CT, ready beyond tomorrow.
I was born with asthma. The best way I think to describe it would be it's like drowning from the inside. It's not being able to breathe out, and that's why people will die. Between being born and being about 9 or 10, I was hospitalised 24 times. It still affects me every day, and I have to take medicine every day. I think maybe being in hospital has made me a bit of a loner. So I think I found my niche in finding that having mates as musicians. They're all very much like me, so we're all slightly geeky and a bit weird. I don't know why I can play the trumpet but can't do other things. It might just be practice. It means a lot. I absolutely love it. Teaching the trumpet is so different because they're getting it. And you can see that they were playing with them like they were toys. That's how it should be. It's fun. So if it's fun for them, it's fun for me. And that's it. And I don't think I'm any different to anyone else in that respect. Because I think everyone has got limits to what they can do. Just mine's a little bit more obvious, maybe. You're fortunate to have a life, so do something with it.
Consider the power of a single component. It can lead to a better image, an earlier diagnosis, a more effective treatment strategy, an improved outcome. Big changes start small. Only by focusing on the smallest of details can we create the greatest value over time. And no one understands this better than the people who design and build our PET and SPEC solutions at Siemens Molecular Imaging.
At Siemens, people and technology come together in a very unique way. And a lot of that has to do with the fact that we own the entire value chain, making a better quality product for our customers, and that's going to help them serve patients every day.
It all adds up to more for our customers. We are the only molecular imaging company that owns every step of the process.
We grow our own crystals. The full chain of taking those crystals and integrating the crystal into the rest of the detector is something we design into this methodology, and we also make sure that we track the quality of that whole process.
Each individual crystal element is hand inspected, and the person who does this particular process handles millions of pixels every year.
The collimators we also design and build ourselves. The materials we use for that provide for consistency and uniformity of the field of view.
We also have an integrated engineering group that does all of our robotics automation, does all of our testing equipment. The purpose is to give us the advantage of having that ability to improve our quality, to manufacture the best detector that we can manufacture.
When every design decision is purposeful, every step of the process is impactful. This philosophy drives the research behind every piece of groundbreaking technology that we create.
We want to make sure that we provide a device that meets the needs of our customers and meets the needs of patients. We don't want to just put a technology out there that doesn't have true advantages to our customers.
The R&D function is complex. We actually have to generate the idea, cultivate it, then bring in the entire team, grow the idea, and bring it to production.
We're very clearly innovation leaders. We make sure that that innovation is focused on real deliverables for the clinical outcomes.
Making a difference means starting small. Day by day, image by image, person by person, we are advancing the field of molecular imaging to benefit everyone, the patient, the caregiver, and the healthcare provider.
Early detection really makes a difference in disease.
That technology, the better image quality, the higher resolution and sensitivity all adds up to great outcomes.
That's really our vision, to enable our customers by giving them reliable, sustainable technology for them to further grow molecular imaging for a much wider population than we're doing today.
Every day, you are giving your very best. We know that and are here to support. The number of obese and multi-morbid patients with coronary artery and vascular diseases is rising. Siemens Healthineers can help you to manage the growing workload, to utilize applications that may help improve clinical outcomes for all your patients, and to make confident diagnostic decisions fast, empowered by our integrated cardiovascular solutions. The perfect support with Siemens Healthineers.
Welcome to the next generation of Syngo Dynamics. Digitalization is changing healthcare today by transforming care delivery. Cardiology departments are being challenged by disparate data systems, decentralized work environments, and increasing amounts of data. The next generation of Syngo Dynamics is the latest centralized digital hub for the entire cardiovascular service line. It aggregates data and information across the enterprise to streamline imaging IT. With a new user interface and intuitive reading, data and images are quickly connected to improve clinical and operational workflows. For informed decisions and better patient care. Perception, understanding, reasoning, creativity, wisdom, learning, intelligence, the ability to think abstractly and rationally and use that thought for purposeful action. The strongest tool of humankind. And a concept that we have pushed even further, making technology our strongest partner and giving us the confidence we need to make the right decisions intelligently. My exam companion is intelligence that works with you. It uses the new possibilities of digitalization to turn data into built-in expertise. To unlock the full potential of ECO Xpre. My exam companion helps users on their way to the consistent results that radiologists need. My exam companion, intelligence that works with you.
Fast temporal resolution, powered by dual source CT. Reducing the rotation time as much as possible to minimize motion artifacts is crucial for some patient groups. While single source scanners have gotten faster, physical rotation time restrictions mean that they can't cross the 100 milliseconds threshold. So, motion artifacts remain a problem. It's a completely different story with dual source CT because the tubes can work together to help you speed up your scans. When you set each tube to perform only a quarter rotation, you still get a half rotation in total. This enables you to achieve resolutions even below 75 milliseconds. As a result, dual source CT is capable of eliminating motion artifacts even during the most demanding applications. Fast temporal resolution, powered by dual source CT. Dual source CT, ready beyond tomorrow.
I was born with asthma. The best way I think to describe it would be it's like drowning from the inside. It's not being able to breathe out, and that's why people will die. Between being born and being about 9 or 10, I was hospitalised 24 times. It still affects me every day, and I have to take medicine every day. I think maybe being in hospital has made me a bit of a loner. So I think I found my niche in finding that having mates as musicians. They're all very much like me, so we're all slightly geeky and a bit weird. I don't know why. I can play the trumpet but can't do other things. It might just be practice. It means a lot. I absolutely love it. Teaching the trumpet is so different because they're getting it. And you can see that they were playing with them like they were toys. That's how it should be. It's fun. So if it's fun for them, it's fun for me. And that's it. I don't know. I don't don't think I'm any different to anyone else in that respect. Because I think everyone has got limits to what they can do. Just mine's a little bit more obvious, maybe. You're fortunate to have a life, so do something with it.
Consider the power of a single component. It can lead to a better image, an earlier diagnosis, a more effective treatment strategy, an improved outcome. Big changes start small. Only by focusing on the smallest of details can we create the greatest value over time. And no one understands this better than the people who design and build our PET and SPEC solutions at Siemens Molecular Imaging.
So at Siemens, people and technology come together in a very unique way. And a lot of that has to do with the fact that we own the entire value chain, making a better quality product for our customers, and that's going to help them serve patients every day.
It all adds up to more for our customers. We are the only molecular imaging company that owns every step of the process.
We grow our own crystals. The full chain of taking those crystals and integrating the crystal into the rest of the detector is something we design into this methodology, and we also make sure that we track the quality of that whole process.
Each individual crystal element is hand inspected, and the person who does this particular process handles millions of pixels every year.
The collimators we also design and build ourselves. The materials we use for that provide for consistency and uniformity of the field of view.
We also have an integrated engineering group that does all of our robotics automation, does all of our testing equipment. The purpose is to give us the advantage of having that ability to improve our quality, to manufacture the best detector that we can manufacture.
When every design decision is purposeful, every step of the process is impactful. This philosophy drives the research behind every piece of groundbreaking technology that we create.
We want to make sure that we provide a device that meets the needs of our customers and meets the needs of patients. We don't want to just put a technology out there that doesn't have true advantages to our customers.
The R&D function is complex. We actually have to generate the idea, cultivate it, then bring in the entire team, grow the idea, and bring it to production.
We're very clearly innovation leaders. We make sure that that innovation is focused on real deliverables for the clinical outcomes.
Making a difference means starting small. Day by day, image by image, person by person, we are advancing the field of molecular imaging to benefit everyone, the patient, the caregiver, and the healthcare provider.
Early detection really makes a difference in disease.
That technology, the better image quality, the higher resolution and sensitivity all adds up to great outcomes.
That's really our vision, to enable our customers by giving them reliable, sustainable technology for them to further grow molecular imaging for a much wider population than we're doing today.
Every day, you are giving your very best. We know that and are here to support. The number of obese and multimorbid patients with coronary artery and vascular diseases is rising.
Siemens Healthineers can help you to manage the growing workload, to utilize applications that may help improve clinical outcomes for all your patients, and to make confident diagnostic decisions fast, empowered by our integrated cardiovascular solutions. The perfect support with Siemens Healthineers.
Welcome to the next generation of Syngo Dynamics. Digitalization is changing healthcare today by transforming care delivery. Cardiology departments are being challenged by disparate data systems, decentralized work environments, and increasing amounts of data. The next generation of Syngo Dynamics is the latest centralized digital hub for the entire cardiovascular service line. It aggregates data and information across the enterprise to streamline imaging IT. With a new user interface and intuitive reading, data and images are quickly connected to improve clinical and operational workflows. For informed decisions and better patient care.
Perception, understanding, reasoning, creativity, wisdom, learning, intelligence, the ability to think abstractly and rationally and use that thought for purposeful action. The strongest tool of humankind. And a concept that we have pushed even further, making technology our strongest partner and giving us the confidence we need to make the right decisions intelligently. My exam companion is intelligence that works with you. It uses the new possibilities of digitalization to turn data into built-in expertise. To unlock the full potential of ECO Xpre. My exam companion helps users on their way to the consistent results that radiologists need. My exam companion, intelligence that works with you.
Fast temporal resolution, powered by dual source CT. Reducing the rotation time as much as possible to minimize motion artifacts is crucial for some patient groups. While single source scanners have gotten faster, physical rotation time restrictions mean that they can't cross the 100 milliseconds threshold. So, motion artifacts remain a problem. It's a completely different story with dual source CT because the tubes can work together to help you speed up your scans. When you set each tube to perform only a quarter rotation, you still get a half rotation in total. This enables you to achieve resolutions even below 75 milliseconds. As a result, dual source CT is capable of eliminating motion artifacts even during the most demanding applications. Fast temporal resolution, powered by dual source CT. Dual source CT, ready beyond tomorrow.
I was born with asthma. The best way I think to describe it would be it's like drowning from the inside. It's not being able to breathe out, and that's why people will die. Between being born and being about 9 or 10, I was hospitalised 24 times. It still affects me every day, and I have to take medicine every day. I think maybe being in hospital has made me a bit of a loner. So I think I found my niche in finding having mates as musicians. They're all very much like me, so we're all slightly geeky and a bit weird. I don't know why I can play the trumpet but can't do other things. It might just be practice. It means a lot. I absolutely love it. Teaching the trumpet is so different because they're getting it. And you can see that they were playing with them like they were toys. That's how it should be. It's fun. So if it's fun for them, it's fun for me. And that's it. And I don't think I'm any different to anyone else in that respect. Because I think everyone has got limits to what they can do. Just mine's a little bit more obvious, maybe. You're fortunate to have a life, so do something with it.
Consider the power of a single component. It can lead to a better image, an earlier diagnosis, a more effective treatment strategy, an improved outcome. Big changes start small. Only by focusing on the smallest of details can we create the greatest value over time. And no one understands this better than the people who design and build our PET and SPECT solutions at Siemens Molecular Imaging.
So at Siemens, people and technology come together in a very unique way. And a lot of that has to do with the fact that we own the entire value chain, making a better quality product for our customers, and that's going to help them serve patients every day.
It all adds up to more for our customers. We are the only molecular imaging company that owns every step of the process.
We grow our own crystals. The full chain of taking those crystals and integrating the crystal into the rest of the detector is something we designed into this methodology, and we also make sure that we track the quality of that whole process.
Each individual crystal element is hand inspected, and the person who does this particular process handles millions of pixels every year.
The collimators we also design and build ourselves. The materials we use for that provide for consistency and uniformity of the field of view.
We also have an integrated engineering group that does all of our robotics automation, does all of our testing equipment. The purpose is to give us the advantage of having that ability to improve our quality, to manufacture the best detector that we can manufacture.
When every design decision is purposeful, every step of the process is impactful. This philosophy drives the research behind every piece of groundbreaking technology that we create.
We want to make sure that we provide a device that meets the needs of our customers and meets the needs of patients. We don't want to just put a technology out there that doesn't have true advantages to our customers.
The R&D function is complex. We actually have to generate the idea, cultivate it, then bring in the entire team, grow the idea, and bring it to production.
We're very clearly innovation leaders. We make sure that that innovation is focused on real deliverables for the clinical outcomes.
Making a difference means starting small. Day by day, image by image, person by person, we are advancing the field of molecular imaging to benefit everyone, the patient, the caregiver, and the healthcare provider.
Early detection really makes a difference in disease.
That technology, the better image quality, the higher resolution and sensitivity all adds up to great outcomes.
That's really our vision, to enable our customers by giving them reliable, sustainable technology for them to further grow molecular imaging for a much wider population than we're doing today.
Every day, you're giving your very best. We know that and are here to support. The number of obese and multi-morbid patients with coronary artery and vascular diseases is rising. Siemens Healthineers can help you to manage the growing workload, to utilize applications that may help improve clinical outcomes for all your patients, and to make confident diagnostic decisions fast, empowered by our integrated cardiovascular solutions. The perfect support with Siemens Healthineers.
Welcome to the next generation of Syngo Dynamics. Digitalization is changing healthcare today by transforming care delivery. Cardiology departments are being challenged by disparate data systems, decentralized work environments, and increasing amounts of data. The next generation of Syngo Dynamics is the latest centralized digital hub for the entire cardiovascular service line. It aggregates data and information across the enterprise to streamline imaging IT. With a new user interface and intuitive reading, data and images are quickly connected to improve clinical and operational workflows. For informed decisions and better patient care.
Perception, understanding, reasoning, creativity, wisdom, learning, intelligence, the ability to think abstractly and rationally and use that thought for purposeful action, the strongest tool of humankind. And a concept that we have pushed even further, making technology our strongest partner and giving us the confidence we need to make the right decisions intelligently. My exam companion is intelligence that works with you. It uses the new possibilities of digitalization to turn data into built-in expertise. To unlock the full potential of ECO Xpre. My exam companion helps users on their way to the consistent results that radiologists need. My exam companion, intelligence that works with you.
Fast temporal resolution, powered by dual source CT. Reducing the rotation time as much as possible to minimize motion artifacts is crucial for some patient groups. While single-source scanners have gotten faster, physical rotation time restrictions mean that they can't cross the 100 milliseconds threshold. So, motion artifacts remain a problem. It's a completely different story with dual-source CT, because the tubes can work together to help you speed up your scans. When you set each tube to perform only a quarter rotation, you still get a half rotation in total. This enables you to achieve resolutions even below 75 milliseconds. As a result, dual-source CT is capable of eliminating motion artifacts, even during the most demanding applications. Fast temporal resolution, powered by dual-source CT. Dual-source CT, ready beyond tomorrow.
All right, Mr. Hajime, I'm sure you have heard the results of all your diagnostic procedures that we did for you. So now it's time for you to go for the treatment itself. We will admit you to a ward and start the preparation for a percutaneous transluminal coronary angioplasty procedure. In short, we call it PTCA.
So I'm not sure about this procedure, doctor. May I know more about this?
Of course, let's take a closer look at this procedure.
Good afternoon, everyone. My name is Hong In. I'm the IT trainer at TC Shanghai. Today, I would like to talk about the percutaneous coronary intervention. So in this presentation, we'll talk about the definition of the PCI, heart anatomy, mainly about the blood supply to the heart, overview workflow, including the routine diagnostic angulation, quantification, physiology assessment, other imaging approaches, ClearScan and ClearScan Live, how to optimize those in cath lab, corindoscope heart GRX. For the introduction, coronary stenosis is the accumulation of fatty deposits, cholesterol and cellular waste product in the inner layer of the artery. You also find the other elements such as calcium. Then over the time, the plaque will build up and narrowing the blood vessel, restricting the blood flow supply to the heart. So patient will have the angina or even heart attack. Then patient will go to the percutaneous coronary intervention, which is the minimal invasive procedure. We try to reopen the narrowing coronary artery and restore the blood flow. Then understanding the vessel supply to the heart is important. According to the Cardiovascular Surgery and the American Heart Association, RCA divided into 4 segments. We have the first one is the proximal from the ostium to the half distant to the acumargin of the heart. Second is the middle from the upper segment to acumargin of the heart. Third is running posterior atrioventricular group from the acumargin of the heart to the origin of the descending branch. 14, we have the posterior descending branch. One is the atrioventricular branch, and the second is the posterior descending branch. Then on the left side, we have the left coronary artery. Fifth is the left main, extending from the ostium of the LCA to the bifurcation. So it's bifurcated into the LAT and LCX. So for the LAT, we have the 6th is the proximal to the origin of the first major septal branch. 7 is the mid from the upper segment to the second diagonal branch. Then 8 is the apical terminal portion of the LAT running along interventricular sulcus. 9 is the first diagonal branch. 10 is the second diagonal branch. So for the left circumflex, 11 from its origin to the origin of the obstial marginal branch, 12 is the OM, 13 is the distal of the LCX, from the origin of the obstial marginal branch and running along posterior left atrioventricular group. 14 is the posterior lateral surface of the left ventricle. 15 is the posterior descending branch. So the overview workflow including the angiography. After the angiography, the doctor will diagnose the vessel by evaluating the lesion, the cause, the shape of the vessels. Then depending on the assessment, patient will be undergoing the PCI. Firstly, we'll look at the angiography. After finishing the patient preparation, doctor will decide the puncture site. The puncture site can be at the groin via the femoral artery, or at the elbow via the brachial artery, or at the wrist via the radial artery. And depending on the different puncture site, we can position our C-arm at a different position. Is to optimize the workflow. For example, if the radial axis is chosen, then the system should be positioned at the head side because we want to visualize the guide wire from the wrist to the aorta. You might also rotate the table 5 degrees. For the femoral axis, the system position should be at the left side because we want to visualize the guide wire at the groin to the aorta. For coronary angiogram, a combination of different angulation is used to visualize the different segments of the vessels. For example, to visualize the LCA, we have the RAO caudal view, LAO cranial view, LAO caudal view. We also call the spider view, RAO cranial view. So, for example, we have the LAO caudal view is the best view to visualize the Lettman bifurcation, the proximal LAT, proximal to the mid of the LCX. Then we have the LAO cranial view is the best view to visualize the mid to the distal of the LAT, then the mid to the distal of the LCX. Then cranial view is the best view to visualize the mid to the distal of the LAT, or the RAO caudal view is the best view to visualize the mid to the distal of the LCX. Then we have the RCA. We have the different angulation to visualize the RCA. Then LAO, cranial, or the RAO. LAO view is the best view to visualize the ostium to the proximal of the RCA. Then the cranial view is the best view to visualize the bifurcation or the distal of the RCAs. Then we have the RAO view. The RAO view is the best view to visualize the mid or the PDA. Also, to perform the coronary angiogram, if you have the Artist 1 system, like the system showing in this video here, you have the special mode called Heart Sweep. Heart Sweep provides an overview picture of the coronary vessel with just one shot of contrast injection. During the ongoing radiation, then the system will do the double angle and rotate around the region of interest. Have the biplane system, the recommendation is to use the combination of angulation from both planes together. It's not only help you to save the contrast for the patient, but also make the workflow faster. Here is the example how we combine the angulation from the frontal plane and lateral plane. So, for example, if you want to visualize the LCA, then for the frontal plane, you rotate the C-arm to the RAO caudal view, and for the lateral plane, you rotate the C-arm to the LAO cranial view. And you can follow this list and store the position into the program position list. So this slide will show you how to store the angulation of both plane into the programmed position list. So firstly, you move the C-arm of the both plane into the desired positions. Then select the zoom side, the wedge filters, then select the store button at the stand control module. Then you find any empty slots from the program position list, then press one or both button of the joystick. But just be careful that please select or isocenter your patient before select any position from the programmed position list. And next, I would like to talk about the benefits of the deep angulation. With the Siemens system, we can achieve the cranial view up to 55 degrees and caudal view up to 45 degrees. So here the example of the LCA from the different spider view. So for the left image, we have the LCA often at the LAO 50 and caudal 30 degrees. This is from the LAO 50 and caudal 45 degree. You can see here the bifurcation separate nicely compared to this view. And Next, we have another example. This is the image taken from the cranial 30 degree. You can see a bit of overlap between the OIT and LCX here. And what if you do the deeper angle? With this image, you do at the cranial 45 degrees, you can see the LAD and LCX separate nicely to each other. If any stenosis happen in between, you easily to visualize the stenosis and measure the stenosis. However, with deep angulation, it might cause a maxar situation. In the maxar situation, you will see the images very noisy, very blurry, and loose of contrast because the system cannot achieve to the requested dose that was set in each protocol. How to know when you reach to the maxar situation? When you look at the left lower corner, you find more important information. For example, here we have Coral If is a protocol name. CM16 is the zoom format. A is the plane A that we are using to acquire the images. Then the voltage, the current, D value, and angulation. The D value here is showing you the detected dose. If you have the smaller number compared to the number that you set at the organ program, which means that you do not have enough X-ray reach to the flood detector. So let's have a look at these two images. So if on the left side, I have a D-value of 135, and on the right side, I have the D-value of 38. And I set the D-value of the OPG is 140, which means on the left side, I have enough X-ray reaching to the detector. And on the right side, the D value is so small compared to the one that I set at the OPG, which means that not enough X-ray reaching to the detector, so that I have a very blurry image, a very grainy image, and noisy image. And what to do in the maxar situation? Firstly, you change the CM angulation, because reduce the CM angulation, you reduce the thickness of penetration. Just remember that increasing the 3 centimeter of the patient thickness will require a double tube output. But to change the CM angulation, you need to discuss with your doctors. Second, switch from the normal contrast to high contrast at the OPG, because when you switch to the high contrast, then it allows the generator to put more output to the tube. For example, you switch from the 10 Röntgen per minute to 20 Röntgen per minute, and be careful that the alarm will be activated when you switch to the high contrast setting. Third, you need to reduce pulse rates or frame rates, because lower the frame rates or pulse rates, it's possible to push more output to the tube without exceeding the skin dose limit. And use less zoom. Change the zoom to the smaller one or the large overview zoom format, for example, from the 16 cm to the 22 cm. It will lessen the dose and you save more tube output. And now we're going to have a look at the diagnosis part. After acquiring the images, the doctor is going to review the images. The evaluation can be based on different criteria. For example, they will have a look at at least 2 orthogonal views, how severity of the arteries, is there any calcification or present of thrombus, because the 2 factors will give them the same angiographic image, while the calcification is suitable for the rotational aorectomy. The thrombus is contraindication to the rotational aorectomy. And then they also have a look at the degree of tuberosity of the vessels, the reference vessel size, the distal vessel, is there any stenosis at the bifurcation part, the grading TIMI, myocardial perfusion. They're going to do the identifying and quantifying the coronary vessels, the collateral vessel as well. Some doctor might follow the AHA classification. For the quantification part, we have one software called quantitative coronary analysis. The software is to measure the vessel with the diameter from the 0.5 millimeter to 7 millimeter. It gives you the automatic control recognition of the stenosis area, gives you the diameter of the measurement, the triometrical and densitometric calculation of the stenosis, like in here in the picture after the quant. Then you have the result here, showing here, or the graph showing here. So in the flow chart, will show you how the doctor going to decide whether the patient need to do the PCI. So after the coronary angiography, they measure the stenosis, and if the lesion is more than 70%, they're going to do the IVUS to see the lesion morphology. Then after that, they're going to do the PCI. If the lesion is between 50% to 70%, they're going to do the physiological assessment like a FFR, IFR. If the lesions is abnormal, then they're going to do the PCI. If the lesion is normal, then they go straight to medical therapy. And if the lesion less than 50%, they're going to do the IVUS and go straight to medical therapy. And now I would like to talk about the physiological assessment. First is the fractional flow reverse. FFR is an invasive measure of the physiological significance of the stenosis. Seeing the coronary angiographic image is often insufficient in guiding PCI. FFR has been widely used to estimate whether the lesions may cause the myocardial ischemia. So FFR is defined as the ratio of the distal pressure to the proximal pressure to the stenosis during the hyperemia. So if you have the FFR value equal to 0, which means normal. If the FFR value is between 0.7 to 0.8, then the patient likely to have the myocardial ischemia. So use of FFR involves a pressure Y that is applied at the distal of the stenosis, like in this image. So prior to this point, you might have several steps you need to perform. So firstly, you need to connect the equipment correctly and mount on the table. Secondly, you need to normalize the pressure between the guide and Ys. Then you advance the Y into the or cross to the stenosis. Then after that, you turn on the hyperemic agent, for example, the adenosine for about 2 to 4 minutes. Then after that, you confirm the result with the pullback. So next is the IFR. IFR stands for instantaneous wave-free ratio. IFR was found in 2012 and has been accepted as a guidance for the PCI decision making. Like FFR, IFR use the intracoronary pressure to provide the estimation of the flow. However, unlike FFR, IFR does not require any hyperemic agent because it measures the stenosis during the diastolic stage where the microvascular resistance is low and stable. So if you have the result of IFR less than 0.9, then the patient needs to undergo the PCI. Then the workflow of the IFR is similar to the FFR, but without the need of a hyperemic agent. So during the PCI, the doctor also used the other method to visualize the lumen of the vessels. One of the methods is the intravascular ultrasound. It's a catheter-based imaging technology which provide the cross-sectional views of the artery. So in the intravascular ultrasound, it uses a small size of the ultrasound probe placed at the end of very flexible catheter. Then the standard frequency used for the IVUS is between the 20 to 60 megahertz. The application of the IVUS including visualization of the blood distribution, dissection of the vessels, and they measure the vessel length and diameter so that the doctor can decide the size of the stent or the balloon. Then they decide the stent landing zone and visualization of calcification. And you might heard the term of the optical coherent tomography. It uses a fiber optic catheter that emits the waves of the near-infrared light. So the application of the OCT is similar to the IVUS, but there is a mild disadvantage of the OCT is the required saline flush or the contrast medium during the pullback because the near-infrared light is attenuated by the blood. And the most advantage of the optical coherent tomography is provide a very high resolution compared to the angiographic image and IVUS. And next, we're going to talk about the intervention. So when the doctor decides to perform the PCI, then a predilation is used to prepare the lesion and allow the stent inflation to achieve the minimal stent area. The balloon should be long enough to cover the lesion and a bit of the adjacent of the artery. So selected balloons is chosen, then is a wide and flush with the heparin, but not inflated yet. After the placement of the correct sheath, then passing the guide wire and then into the lesion, the doctor is using the 2 balloon marker as the guidance. Under fluoroscopy, they can see the 2 balloon marker, so they can decide where the location of the balloon is. After inserted into the appropriate lesion, they going to inflate the balloon without any delay to avoid the thrombus formation. So under fluoroscopy, the balloons also use the 50% of contrast, so we can see the full profile of the balloon. So this is the predilation. You can see a bit of narrowing of the artery. Then after the balloon inflated, you can see the stenosis area is already opened up a little bit. After detecting the balloon, then stent is inserted into the artery. The stent length should be calculated based on the angiographic image or IVUS image or the OCT image. Stent also have 2 balloon markers, and these 2 balloon markers help the doctor to visualize where the stent is and decide the landing zone. And after placed into appropriate lesion, then the stent is inflated or the balloon is inflated and stent is deployed. However, it's really hard to see the stent structure under the fluoroscopy scenes or acquisition scenes, especially you need to see whether the stent is underexpanded, mispositioned, and stent kissing. You need to visualize the location of the second stent. Cardiologists will use the clear stent and clear stent light functions to visualize the stent. Firstly, with the clear stent, it improves the visibility of the stent in the static view. You can check the stent structure, kinking, decrease of expansion, and calcification information. Like in this image, you can see the bit of underexpanded of the stent due to the heavy calcification. And in here, with the stent kissing situation, the doctor need to see the location of the second stent if the second stent is already overlapped with the first stent. To be able to do the clear stent pre-processing, you need a cardiac scenes or fluorescence. In that scene, at least 25 frames without the contrast medium. And you need to see clearly of the 2 balloon markers. With the clear stent light functions, it allows a real-time verification of the stent positioning while moving the device. So it eliminates the cardiac movement like in these 2 videos. So you can see here in this situation, after confirming the location of the second stent, then the doctor can deflate the balloon straight away. So in general, if the stent is not fully expanded, then a higher pressure balloon is used to help the stent fully contact with the arterial wall, and it prevents the arterial restenosis or acute closure after the angioplasty. So in this situation, you can, based on the clear stent live scenes, you can check whether the balloon is already aligned with the stent, so you're not damaging the adjacent artery. So in order to do the clear stent light scenes, firstly, you need to select a clear stent light protocols, then do the acquisition at the zoom 3 or below, and you need 2 balloon markers presented at the scenes. If the dose of the fluoroscopy is mismatched, then acquisition will be double the dose of the fluoroscopy scenes. Clear stent live have lesser dose compared to the acquisition scene, but a bit higher than the dose of the fluoroscope. So next is the bifurcation stenosis. Bifurcation stenosis is a block distribution unevenly at the bifurcation segment. So if there is any stenosis more than 50% at the adjacent to or at the ostial of the side branch, that is considered as a bifurcation stenosis. There's a multiple classification system available to evaluate the stenosis at the bifurcation parts. So if such as the medial or duct, that we consider the stenosis at the proximal membrane, like in here, or distal membrane or the side branch as well. They also consider the angulation between the membrane and the side branch. So these factors will affect the treatment techniques and the result of the revascularizations. Optimal approach for the coronary bifurcation is still debating. One of the technique that they are using is a kissing balloon technique. So in this picture, after place the first stent at the membrane, they're going to insert the balloon to into the side branch to project an ostium. Then the next one, they're going to insert the second stent at the side branch, and then they're going to do the inflation of 2 balloons together, one at the side branch with the lesser pressure compared to the membrane. So next is a chronic total occlusion. Chronic means duration typically more than 3 months, not an acute sudden onset. Total means that the nearly blockage of the artery. So not all the patients with the CTO show the symptoms, but some might have the symptoms like angina, shortness of breath, rapid or irregular heartbeat. So for the chronic total occlusion, traditionally they're going to do the bypass graft surgery to treat the blockage. But nowadays, with the new technology and new percutaneous technique, cardiologists are now using the special guide wires and catheter to treat the total blockage. So the treatment strategy can be the antegrade or retrograde. So they were based on the anatomical evaluation. Firstly, they need to look at the CTA data, the proximal cap property, the length of occlusion, the distal cap of the occluded vessels, then is there any collateral vessels. In this flow chart, they will show you how the doctor going to treat the chronic total occlusion. They will look at the proximal cap first. If it clears, then they're going to do the antegrade. If it no, then they're going to do the retrograde. The antegrade guidewire will advance from the proximal cap to the distal cap. But if the proximal cap is not good, then they're going to advance the guidewire from the distal cap to the proximal cap. And if it failed, they're going to do the dissection re-entry. There are too many challenges in the CTO case. Proper patient pre-selection is required. The guidewire crossing the CTO can be performed blind as you cannot visualize the distal part of the vessels. Then higher fluoro time or the procedure time due to the heavy calcification. High amount of contrast can be used. Then the cardiologists who performing the CTA case need to be a very, very high skilled and experienced. And because of the too many challenges, so they might use the single CTA guidance. Single CTA guidance is not used to detect an occlusion, it's used to provide the guidance during the case. So it provided ability for you to safely plan and perform the case under fluoroscopy scenes or acquisition scenes. Then single CTA guidance use the CT data and create the segmentation of the arteries. Then based on the segmentation, the coral tree will be created and then used to overlay with the fluorescence as a road map. Then the doctor will see how they navigate the guide wire using the guidance based on the CT data. So this is called coral way. The coral way here provides you the color coded. When it's in green, which means that this vessel is not shortening. When it's in red, then in this view, the might rotate to another angle because the vessel is already shortened. So the overview workflows, including the planning. The planning is you import the CT data into the single workplace, then use the single CTA guidance to plan the segmentation. After that, you can register the patient and overlay the cover way onto the 2D live fluors. With the chronic total occlusion, you might see the doctor using red bladder. This is the image of red bladder by the Boston Scientifics in this video here. So in the video here, you can see the red bladder just move up and down to apply the calcium. To be able to optimize the dose in CAD lab, you need to understand the effects of radiation dose. We have two effects. One is the deterministic effects and one stochastic effects. So for the deterministic effect, is it predictable? The probability and severity increase with the dose, and there is threshold value. So a patient will have the skin burn, the dermonecrosis, or erythema. So for the stochastic effects, the probabilistic in nature, the severity has no relationship with the dose. Then the likelihood increases with the dose, but no identifiable threshold. And you need to look at the exposed area. Increasing the exposed area is mean that you're increasing the stochastic effects. So patient will have the tumor or genetic effects. How to look at the values? For the deterministic effect, you need to look at the patient entrance resonance point. And for the stochastic effect, you need to look at the DAP or KAP. So the values will be displayed either at the monitor outside the control room or at the examination room monitor. So we have two values displayed. First is the accumulated air karma or air karma rate at the PERP, and then the second is the dose area products. So the first one is related to the deterministic effects, and then the second one will be related to the stochastic effect. So how the dose or the value measure at the system? We have firstly the system dose is either detector dose that we set at the organ program, which is related to the 22 cm. If you increasing the dose or you're increasing the zoom, then you're increasing the dose. And the second one is the skin dose, which is measure 30 centimeter in front of detector. This is country limitation or the country independence. For the normal country, like in Vietnam or Germany, if they set the normal contrast, which means they're using the 10 Röntgen per minute, or if they set high contrast, then it means that they're using the 20 Röntgen per minute. For the low country like Japan or New Zealand, If they set the normal contrast, which means they're using 6 Röntgen per minute. And if they set the high contrast, which means they are using 14 Röntgen per minute. And the PERP or IRP at the formal name, then it's in measure 15 centimeter below the isocenter. So this point is defined by IEC regulation. So when you want to optimize the radiation dose in the cath lab for the staff inside the room, please use all the care functions that are available to reduce the dose. Only use higher dose when needed, and use the collimator, lower the frame rate, use the filter, and try to stay as far as possible. Use all the shielding that are available inside the room. And next, I would like to introduce you the Corindus CodePath GX. Corindus was invented by an interventionalist cardiologist and his students in 2002. Corindus created a safe working environment by reducing a significant radiation to the operator. So it robotically measures the anatomy and advanced guide wires and capitals and stand via the joystick with a millimeter by millimeter. So we can improve the accuracy of the procedure, especially in the stand placement, so that we can improve the patient's outcome. So here the video.
CorePath GRX is the second-generation robotic system for cardiovascular interventions. The CorePath system offers the physician robotic control of the guide catheter, guide wire, and balloon stent catheter from the protection of the radiation-shielded cockpit. As with a traditional intervention, the physician gains access manually. In preparation for CorePath, the physician attaches the drive gear to the Y connector and then connects the guide catheter. With CorePath's bedside unit draped, the scrub staff employee moves the extended reach arm into position. You can now see the single-use cassette mounted on the robotic drive, which is where the interventional devices will be loaded. The physician loads the guide catheter into the single-use cassette using the fine-tuned controls on the robotic drive. With the guide catheter securely in place within the cassette, the physician pulls the guide support track over the guide catheter, securely attaching it to the introducer sheath. This guide support track supports the guide catheter as it is being advanced and retracted within the patient's anatomy. Once the guide catheter is in position, the physician can now remove his lead and sit down within the radiation-shielded cockpit. From here, sitting less than 2 feet away from the CorePath's Power Vision monitor with enhanced visualization, the physician will drive the devices and perform the intervention. The scrub staff is now ready to load the devices. The bedside touchscreen provides step-by-step instructions to streamline workflow throughout the case. Once the devices are quickly loaded into the cassette, the intervention is ready to begin. With the guide wire position locked in place within the cassette, the scrub staff adjusts the radiation shield to maximize her radiation protection and steps away to minimize her radiation exposure. The physician can advance, retract, and rotate the guide wire in order to cross the targeted lesion. As necessary, devices can be quickly exchanged by the scrub staff throughout the procedure. The physician can reposition the guide catheter using the guide catheter control joystick located on the control console. When the procedure is completed, the scrub staff follows the instructions on the bedside touchscreen to end the case by removing the devices from within the single-use cassette.
And this is the end of my presentation. Thank you for listening.
Hello, ladies and gentlemen. Thank you for accompanying me on this journey. I couldn't have done it without your support. After going through so many procedures, I finally sat down with my doctor and she went through all the information with one system. It was easy for me to understand as she went through the images and the report with me, for the making of an informed decision. I would love to show you this system as well. For an easy access to all the images and report, a centralized digital hub is required for a complete cardiovascular service line. Single Dynamics offers a unique 360-degree view of patient entire cardiovascular service line, and it is a powerful reading and reporting system. Let's have a look on Single Dynamics.
Good morning, Dr. Serena. My name is Ketun. I'm the application specialist from Siemens Healthcare. Thank you for your time to attend the sessions for Single Dynamic. Today, I would like to guide you through the features and functionality available in Single Dynamic, which could help you in reading and reporting the studies done for Mr. Hajime. Let's take a quick look at a typical cardiology workflow without Single Dynamic. Cardiologists are focused on outcomes. The technologists will take the images and make measurements either online or offline. The spectacular images are transferred into different packs depending on imaging modality. Technician or clinician post-process images and make additional measurements in different post-processing applications such as QLab, Contact, Single via, Corridor 4DM, Circle, and etc., where they can be analyzed and turned into actionable insights and support patient treatment or procedure. The data and images are manually entered into structured report. Final report and images are transferred into the EMR. What will be the difference with Single Dynamics? Let's take a quick look at the typical cardiology workflow at Single Dynamics. The cardiologist are still focused on outcomes. The technician will take the images and make measurements either online or offline. Images are transferred into Single Dynamics where they can be analyzed, turned into actionable insights, and support patient treatment. The data transferred is compared with reference and normality values based on guidelines and policies. Again, the physician can make additional measurements or calculation as needed between Single Dynamic. For example, in echocardiology, the study isn't done when the patient leaves the lab. Diagnosis continues with additional measurements and calculations and analysis of images in Single Dynamic. These datasets are automatically populated into the structured report with no manual input needed. The reports are automatically generated based on the data and study type. This seamless integration allows the cardiologist to effectively diagnose and treat the patient based on best practices and the latest clinical data. Single Dynamic is the cardiovascular imaging and information solution that is designed to be the centralized digital hub. It offers a unique, complete view of the entire cardiovascular service line, from diagnosis to therapy and then follow-up. Single Dynamic creates the backbone to connect modalities and IT systems along the care pathway. It enables the sharing of data and information across the hospital to help facilitate data transfer and drive the best outcomes. Care teams have access to the complete patient clinical information from various sources, such as bidirectional data export from EMR, to provide more holistic view of the patient for informed decision and better patient care. Single Dynamics continues a long tradition of departmental IT excellence by adding the global knowledge of Siemens Healthineers. We are working with Single Dynamics for more than 25 years. It started as a workstation for ultrasound and evolved to be a multimodality solution during these 25 years. Up to date, we have more than 550 single dynamic systems installed worldwide. In ASEAN, we have 2 install base in Philippines and 2 install base in Thailand. We bring together expertise in all aspects of cardiology information and image management, making Single Dynamics a robust, multimodality, vendor-neutral, centralized digital hub for the cardiovascular service line. Until today, we continuously working hard to innovate the cardiovascular service line while delivering consistent high-quality outcome. This critical solution is enabling the team of cardiologists to achieve their goal by, firstly, efficiently access study data across imaging modality and throughout the enterprise. Secondly, provide a consistent reading and intelligent reporting platform to connect the right data faster, avoid missing or conflicting data, and thereby driving higher quality outcomes and faster reimbursement. Thirdly, simplify the operation to reduce operational costs while laying the foundation for enduring growth. We help our customer saving 20 minutes per report by using Single Dynamic with Tomtec integration, congenital and vascular diagram, and added new measurement from QLab strain. We have 3 different deployments for Single Dynamics. Single Dynamics Workplace. Single Dynamics Workplace is the workstation which is installed in the office or reading room. The doctors can read and report the studies with various tools and functionality. Single Dynamics Portal. Single Dynamics Portal is a remote workplace. The functionalities available in Single Dynamics Portal is similar to Single Dynamics Workplace, but Single Dynamics Portal is installed on the doctor's laptop. The doctors can read and report the studies over low bandwidth network, especially if the doctors need to do the reporting from home or from other branches by using image call-out functionality from the EMR. Single Dynamics Mobile. Single Dynamics Mobile is a zero-footprint viewer. The doctors can review images and PDF report on their mobile devices or tablet. This brings convenience to the doctors when they do bedside consultation. So, with Single Dynamics, doctors can make fully informed decisions with images and information through secure access from anywhere at any time. They can access from any workplace in the hospital and not limited to the workplace in his or her office for reading and reporting. They are also able to access studies from tablet or mobile devices for bedside consultation, remote viewing, and also to provide a second opinion. Single Dynamics provides seamless user experience through common and consistent user interface across platforms. On top of that, Single Dynamics Workplace and Single Dynamics Portal are compatible with Microsoft Windows 10. These enhance the security features and help the hospital to develop policy to comply with privacy and security regulations for controlling access to protected health information. Single Dynamics support a wide range of DICOM modalities. We can connect to cardiac catheterization angiography, electrophysiology, ECG, cardiac CT, and cardiac MR, and also nuclear cardiology. We also support other imaging systems such as echocardiography, vascular ultrasound, and maternal fetal medicine. With this, Single Dynamics provides a complete imaging record to the user while reporting. We also continue to support DICOM structure reporting for qualified acquisition system. DICOM structure reporting provides the most robust open interface to the imaging modalities with generating the studies and data from the patients. Once the report is complete, Single Dynamics provides the capability to move the data in a variety of formats. These include BMP and TXT files. We can also send the files to other information systems such as HIS through an interface engine or broker. Now let's take a deep look into the cardiac catheterization angiography. Single Dynamics and Sensis Vibes provide real-time bidirectional integration. Single Dynamics can read the data in Sensis Vibe SQL database. Any changes made in either Single Dynamics or Sensis Vibe will be synchronized in real time in both systems. The waveform, as you can see on Sensis Vibe monitor here, can be transferred to Single Dynamics as well. This enables complete and consistent data transfer for hemodynamics and electrophysiology measurements to the reporting field in Single Dynamics. Besides, we also support FFR through Sensis. On top of that, in Single Dynamics, we also have the capability to support other image types such as OCT and IVERS. Besides connecting to Siemens Sensis Web hemodynamic system, Single Dynamic as the vendor-neutral cardiovascular information system also able to import the hemodynamic and electrophysiology data from Merge Hemo, GE MacLab, GE ProCar Cardio Lab, Philips With System 4, and Philips Cypher. This provides seamless interface for easy reporting and expeditious reimbursement. It is possible to customize the reporting templates. There is the possibility to have the structured report in the table that is created according to the user preferences. Tabular approach in the worksheet enables efficient documentation of abnormal findings in the coronary arteries. The data and measurements automatically flow in real time from cath lab and hemodynamic systems into templates and automatically generate the reporting text in structured report. This will streamline the workflow and reduce the report turnaround time. However, Single Dynamics still support the option for free text and voice recognition input if it is required. The smart reporting features in Single Dynamics enable us to customize the mandatory fields, ranges, and alerts. The orange fields that you see in the worksheet are mandatory fields. Users cannot sign off the report without filling in those mandatory fields. This will ensure that the data needed for the registry reporting will be available for export at the end of the year. The measurement or reading that is out of normal ranges will be highlighted in red color. This will help to bring the user attention to the abnormalities and will help to make informed decisions for the patient. The worksheet can be customized to support export of configurable structured report for distribution to registry. Let's have a look on how the user can use Single Dynamic for reporting. In this example, the user is doing the diagnostic coronary assessment using the tabular worksheet, and he put in the PCI command. The auto text will be generated according to the information inserted in the worksheet, and the command will also be inserted into the generated report. Multiple reports can be associated with a study. Each clinician can independently review and sign off on their respective report as part of the overall patient study. In this example, the diagnostic cath and BCI clinicians are different. Both clinicians can sign off their report independently. This provides the flexibility to the user and streamlining in the report turnaround time throughout the enterprise. Now let's talk about the coronary tree diagram. We can have the coronary tree summary, which is depending on the information inserted in the coronary tree diagram. Single Dynamics will automatically create the summary in the report. This is not only from the diagnostic perspective, but also the intervention as well. If the clinician do the diagnostic first and later on the intervention procedure, the clinician can use the same coronary tree diagram. Single Dynamics will automatically put the intervention in the resulting text. And here, I have a little bit more details about the congenital heart diseases diagram. We have more than 157 diagrams from Marlin-Meyer library. If the user would like to add their own diagram, they will be able to do so. The user can easily modify the anatomy to illustrate surgical repair, unusual anatomy, catheter causes, devices, and more. Diagrams can embed auto measurements directly, driving a quick and better understanding of complex congenital heart defects. Next, let's have a look on how we can use Single Dynamics for CT and MR examinations. CT and MR studies can be easily accessible from Single Dynamics Enterprise Study List. User can review CT and MR studies using Single Dynamics Viewer, or if the user needs any advanced post-processing, with click of a button, user can access to Single View for advanced visualizations and functionalities. Reporting can be done through Single Dynamics Structure Report Template. Same as CT studies, MR studies can also be easily accessible from Single Dynamics Enterprise Study List. With click of a button, direct access to advanced visualization functionality is also possible through Single View. User can do their reporting through Single Dynamics. Now let's go to another modality, which is nuclear cardiology. Single Dynamics is tightly integrated with Corridor 4DM for nuclear cardiology. Once the user opens the nuclear cardiology studies in Single Dynamics, it will automatically launch Corridor 4DM in the same study. If there is a two-monitor setup, the report and worksheet will be open on the left monitor, and the images with measurements will be open on the right monitor. The measurement done in Corridor 4DM will be automatically populated into the worksheet, and customized sentences will be generated in the report. Let's talk a bit about analytics. In cardiology, we collect a lot of data, but how do we turn the data into actionable insight? I have an example here. A cardiologist would like to have the information about all patients with severe aortic stenosis for the past 6 months for the cardiology rounds discussion. He would like to pick some interesting cases for his presentation. So, how we can help him? Single Dynamics have an on-site graphical analytic tool with CSV output for simple access and analysis of data. Besides, Single Dynamics also come with Microsoft SQL Reporting Services, SRSS. With Single Dynamics Data Mining Tool, the user can query the data based on different criteria. They can create, modify, or delete how data is exported based on the study type and the study status.
They have the capability to configure number of studies and the frequency of export based on departmental needs. Besides, the user is also able to configure export location of XML file based on study type. The user can also do manual export from within workplace. With Single Dynamics data mining tool, the user will be able to query the data based on different criteria. For example, study date, patient height, patient weight, and so on. The user will be able to create, modify, and delete how data is exported based on study type and status. They can configure number of studies and frequency of export based on departmental needs. Besides, the user also have the ability to configure export location of XML file based on the study type. On top of that, they will be able to manually export the data from between different workplaces. This tool is very useful for the clinician to query the clinical information. For example, the doctors would like to have the data for all patients with severe aortic stenosis for the past 6 months. How about the operational data? Can Single Dynamics query the operational data? Yes, we do. We have the SRSS Analytics report. We provide multiple CAN reports in Single Dynamics SSRS. And we are growing the number of CAN reports. SSRS is very good for administrative data. For example, if the administrator would like to know the number of studies done after office hour, they can use this template. And if they would like to know the number of amended report, they can simply click on this template. Let's talk about some general functionalities in Single Dynamics. The user has the capabilities to import the studies easily from any shared location or devices into Single Dynamics. For example, if a patient brings a CD to your department, you can easily import the studies from the CDs into Single Dynamics. On top of that, if you need to burn a CD for the patient, you can easily export the studies to any external media or to a shared folder. In terms of worksheet template configurations, Single Dynamics provides shared tab features for quick and easy standardizations of worksheet tabs across different study types. Worksheets that sharing the same tab will be automatically updated across template when changes are made to any shared tab. This is beneficial for multi-site or multi-department customers. In terms of security enhancement, Single Dynamics provides auto log-off functions. Single Dynamics will be automatically logged off after a certain period of inactivity. System administrator has the capability to configure the auto log-off time based on unique customer needs. Next, I've invited a colleague from US to give us the demo of Single Dynamics.
So let's go ahead and log into the application. And you now see the study list. Some of the things that we can mention are the ability to change the columns, right? So I can customize what columns are on the list, and I can move the order around. Of course, I still have the ability to move the columns around the list and to adjust the sorts if I want to do that. And these customizations are sticky to the user. So anywhere now that the user goes in the enterprise, they'll be able to access this study list with the settings and the configurations that they've set up. That's really important because sometimes our users go to lots of different places across an enterprise, and we want to ensure that when they go into Single Dynamics, they know exactly where they are, and they're going to have a consistent experience. They're not going to be lost looking for data. And even to enhance that statement a little bit, so right now we are logged into the full client. This is our full reading and reporting client, but there's also the remote client that we could use in a low bandwidth situation, and the web portal. And both of those other platforms, the remote client and the web portal, also share this exact same study list. So it really is going to be a consistent experience as we look across those different platforms. I'm going to come back to our filters in a second, but I want to spend a second before that to look at the quick search bar, which you see in the middle here. So one of the first things is that it operates far more like a Google search. And is going to be far more forgiving of your search. I'm going to go ahead and put a name in. So I will look for my famous Jerome. And you can see here that I could just type the name in naturally, Jerome space, and I just put the first part of his last name. In addition, you have the ability to search for things like study types or even dates. So I could, for instance, put in Jerome's birth date and pull up all the studies by that birth date. Maybe that could be the study date if you wanted to do it that way. You could also do the patient ID, and I can find him that way. So I don't have to define what this value is. The system is smart enough to be able to figure it out and give me the return. All right, back to the filters. And I'm going to try and demonstrate for you, which is called the advanced search. So, and if you click on it at first glance, again, where you've got a number of different fields that you can do a search against your database and create sort of a custom study list. What's nice here, though, and what's the big thing, is that you have the ability now to save these as your own custom filters. So for instance, I've got one here called MVP patients, and this is looking at my diagnosis field for containing MVP. Or maybe I want to, in this case for my demo system, look at my custom one field, anything that has demo. If I search, then you can see that I've brought those studies back. Maybe bringing it a little bit closer to our customer's use case. Maybe they want to do something. Let's go ahead and remove this field and set up a custom search on the report. So I'm going to bring my report field in. This is going to say contains, and I will put in LVH. Maybe LVH is a keyword on my reports for my hypertrophy studies. So we can name this query LVH studies and save it. And now I won't run it, but instead I will go to my list and show you now that this is a filter in the list. And I can click on that and quickly find just those studies that relate to that custom search I've built. Now, just to bring this all together, this whole study list, as we've said, travels with me anywhere on the system. So now as a user, anywhere I log in, I will have access to this custom search that I've created. And that really brings quite a bit of functionality and flexibility to the study list, enabling our customers to find exactly what they're looking for as quickly as possible with this study list. So I'm just going to go back to my today's list for now. I'd like to take a look at the CATH side. And we talk a lot about our bidirectional integration with Census, but I think we do a lot of talking. Maybe you've never actually seen it in action. So I'm going to try and actually show you what this looks like. So at this point here, where I'm actually going to go ahead and leave Single Dynamics and go to my my Census Vibe. So you see here now I've got a simulation of my Census Vibe workstation. This is probably located somewhere in my cath lab, and I've got somebody in the cath lab that's been documenting the case. So they've been going through already and collecting different pressure readings during the case. They've been adding procedure notes along the way. And they also have been doing things like adding medication. So I'm going to go ahead and add a medication. And let me go ahead and type in, we'll add some Versed because this patient was a little bit anxious during the procedure. And I'm going to type in my amount, the route. We'll say why it was given and by whom it was given. And of course, we can go through and add all of that information. And this has been done over and over in Census Vibe to build up the case. So again, because this is not a Vibe demo, I won't spend too much more time here, but let's go ahead and jump back to Single Dynamics. So now I'm back at Single Dynamics. And let us suppose that the case has ended and the interventionalist has left the cath lab. They've gone to their office where they now find right in their list the study that they were, or the procedure that they were just working on. So they can open it up. And of course, we see all of the fluoro images that were acquired, hopefully maybe from our artist lab. And they navigate through and look at those images in the same way. Of course, we can appreciate that, again, this is one system, the same system that we were able to look at our echo studies in. And of course, we can go ahead and display those side by side. So sometimes that's relevant for the case. But in this case, we want to just get the report done. So I'm going to go ahead and launch my report and worksheet up. And this will be very similar now to what the physician will encounter right out of the gate. So you can see here that a great deal of information has flowed into us from Census. So things about the lesion that we've talked about, the pressures that we've acquired, the conditions and the procedure logs, and also that medication that we entered. And it's at this point, maybe a physician's looking through and realizes, ooh, this says 20 of Versed. I'm pretty sure we only gave him 2 of Versed. So I need to correct that before I finalize this report. Well, from the worksheet, now instead of looking at a DICOM SR, we actually have access to the hemo data that was entered. So we can go ahead and change this now to 2 of Versed, and maybe actually the person that gave it was wrong as well. We can change that and close. And I'm feeling pretty good because I look at my final report and see that that now says 2 of Versed, and it was given by my Dr. Ringo. So this is good, right? Well, it's good on the physician report, but what about the interventional documentation? Is it changed on Census? The concern may be that I need to run back to the cath lab and try and grab my documentation person and let him know about this mistake and get him to fix things before he moves on. But with the bidirectional, we don't have to do that. So let's go ahead and go back to Census. And from here, we'll go ahead and look at our medication, which we entered, and you can see now in the database that it is actually reflecting the amount of 2 and the physician name that we changed it to. So these databases now stay in sync, and that allows me as a physician to make a change in my my report on Single Dynamics and know that it's going to be in harmony with the documentation that is being driven from Census. So there's a great advantage there. Of course, we have talked about also being able to to work with other hemodynamic systems. So could be other third-party systems out there in the world that you have to work with, and we can support those. But with Census, we really have that nice and unique bidirectional use case, and that is very strong for us to be able to show. All right, let's go back to the study list. We do look at echo and at cath quite a bit, but perhaps maybe our users also have other modalities. So let's think about nuclear real quick. And this is an opportunity for us to show our nuclear workflow, which utilizes the 4DM corridor nuclear medicine viewer. So I'm going to go ahead and launch my study, and I have my report and worksheet engine, which will come up, and you can see that my corridor is launching in, let's say, real life. This will be on my secondary monitor, and my report and worksheet will be on my primary. But of course, we're consolidated in here, and we've got really a very robust workflow engine here for nuclear. So this is quite configurable for different use cases. And we've got the different processing steps that our techs may go through as they prepare this study. And then to the quantification, including the different bullseyes, which the physician can come through and modify as they need to. Even coming to the function and even a summary page, which they can see and get an overview of the study. Now, what's nice about this workflow is that all of this information is also coming into and can be mapped into a report. So, for instance, those scoring bullseyes that we did in NVIA are also showing up here, and the scores that we've created are going to flow in, and that's going to build our report in the same way that the structured report from SR, those measurements that we had from echo, helped to build our report. And then on the cath side, the data coming in from our hemo system helped to build it. We get the same in nuclear medicine. So it's really that structured report. It's the same engine now that we've looked at across echo, cath, and nuclear medicine, and it's evidence-based. So the values that we have are driving our observations and building the phrases in our report. All right, I'm going to take one more step along the way before we close out, and let's go ahead and go to our CT department. I've got some studies here, and with CT, again, we heard a little bit about how VIA can also be used with Syngodynamics. So here's our Syngodynamics study list, the same study list that we configured in the beginning of the demo and really customized to our own user. I'm going to go ahead and open a study, and you can actually see that when I double click on it, I'm launching right into VIA. So as that happens, I'm going to toggle back to my primary monitor, which is my Syngodynamics. I do have my report and worksheet, which I can navigate through and do my reporting here. But I also have my single VIA in all its glory. So of course, I can do my 3D visualization on here and all of the different workflows. And this is an incredibly powerful advantage for us to be able to show this as a best of breed advanced visualization, tightly integrated into Syngodynamics. Now, let us just say, at this point, we should mention that the findings are not flowing over. And what we can do, we can have a reporting engine now which spans multiple modalities. It's the same engine, so we're not learning and configuring different engines for different modules. This really is one thing that users can use across Syngodynamics. Let's go ahead and try and show you what this would look like on my iPhone. So our users, of course, when they hear about this web portal, they get excited because they're thinking about being on call and wondering if when they're on call, they might have to log into a PC or drive into the hospital. And so that's why now this use case of having my phone be able to log in is pretty nice and pretty important to show to our customers. So you can see here, we'll go ahead and show our study list that we've created. Again, as I mentioned, that same study list follows me. It really truly follows me to any platform that I'm on. From here, I can go ahead and open a study up. So it's going to call that study up, and I'm going to be able to look at it on my phone, including things like controlling the clip. So maybe I want to scrub it again frame by frame, and I can actually do that right from my iPhone here. Maybe also want to do things like magnify, and I can just do that with the pinch action to really look in at specific areas of an image. And of course, from here, I can navigate through my departments. So maybe I need to go to the echo department. No problem. We can switch over. We can access those images very quickly. Maybe look at our whole set of thumbnail images and jump to specific place in the study. So there we go. And as was mentioned, we also have access to the report. So I can now see my clinical report here as well. And this is all literally right now in the palm of my hand. This is not a separate app. This is actually a true zero footprint web-based application. So I'm just using my Safari browser on my iPhone to access it. But I have access to all of this information here from the phone.
Ladies and gentlemen, it's time for another coffee break. Please be back in 10 minutes time for our panel discussion session, where all your questions will be answered by our experts. As a reminder, you can still submit questions through the chat pane. See you in 10 minutes.
today's session gave you some valuable insights on how different imaging modalities complement each other from diagnosis to treatment. Of course, the approach may differ between clinicians and patients' conditions. But we do hope that after this symposium, it will trigger your curiosity and interest in learning about the other modalities and recognizing what system features are available for you and your patient. Before we end our symposium, I'd like to remind all speakers to turn on your cameras and put yourself on spotlight for the question and answer session that's about to happen. We will collate the questions from the chat panel and address it with our speakers. Our panel will gladly discuss the answer with you now. And it's over to you, Niam.
Good afternoon, everyone. Thank you, Serena. My name is Niam Fazin, and I'll be your moderator for today. So we do gather all our panelists for today. So thank you for the participants for staying over on the morning sessions and also in the afternoon session. So some of your questions already answered in the chat pane, and some questions we will discuss now in our panel discussion sessions. I'm going to share my screen so that we can see the questions together, and then I'm going to call up the panelists to answer the questions. Just give me a second. All right. So the first questions, goes to our panel from the X-ray product. So here the participants ask whether the parameter like KV and MAS automatically ready or it can be adapted manually. So let's go to, yep.
Okay, hello everyone. Can you hear me clearly?
Yep.
Okay. Okay. So first, thank you for your question. So the question about the parameter, yes, we have the two ways to control the parameter. First is manual selection of the exposure factor, which is the KV and an MAS. We can adjust this parameter by manually. However, it will depend on technology's experience. And in some situation, maybe it will result in a poor exposure, especially with those obese patients. The second way is we using the AEC to measurement the quantity of the radiation, which is the MAS. This means that the MAS will automatically defined by the AEC chamber and the KV is defined by the technologies. This solution will help us this have allowed to keep the image quality stable for all the patient. And the question number 2 is about the value of the KV. Actually, in some textbooks and the guidelines, the KV was recommended as the 125 kV, and as I already mentioned in the presentation, actually the parameter is also depend on your hospital setting, and especially it is important to follow the manufacturer recommendation of your system as well. Just keep in mind that please do not set the KV too low. For example, just 60 to 70 kV will not only not enough penetration of the body part, but also increase the contrast, which means increase the difference between the black and white, and that will make the information container of the lungs and the mediastinum is decreased.
All right, thank you. So that means the X-ray system now equipped with the AEC. So that means we give the full control for the system to use its intelligence to adjust the dose based on the patient size. But at the same time, also we can choose whatever KV that we want according to the patient size or depending on the image quality that we want. Is it correct?
Yes, that's correct. Thank you for brief the question, the answer.
Thank you for the answer too. All right. So let's go to the second questions. I believe in your presentation just now, you're mentioning about the artificial intelligence on collimation. So this is very interesting. So does it, this AI collimations can be used for all body examinations, all body parts?
Actually, for the topic today about the cardiology, so I haven't had chance to mention other features which also using the AI collimator, such as we have the auto long leg, auto full spine collimator when we have exam with the auto, and we have this function on the system calling multi impact and auto AI collimator for other part is a really great idea and it is under development. I would say that. And I do hope that we can expect this function in the near future with the Siemens system. Okay.
Yeah, that's very nice. And I believe this artificial intelligence on the collimation is not only benefit on the radiographer itself, but it's definitely that benefit on the patient, isn't it?
Yes.
All right.
And actually, we can, if we are concerned about the AI collimator, we can combine with the photo collimation to do the other part examination. It's also, we can do the collimator easier and less effort than before as the traditional way.
All right, that's very nice. So let's go to the next questions. Is there any radiation safety functions to show the dose received by the patient for chest X-ray especially? And if the patients came back for maybe a repeat examinations or another examinations, maybe within like 1 month or 2 months, is there any radiation safety functions to actually show or tell the radiographer that this patient recently did a chest X-ray?
Okay, so that's a really a great idea for the dose monitoring for the patient. Yes, on the system, on the Siemens radiography system, even the mobile X-ray, we all have the dose report so that we can recording the dose for the patient. Even the patient need to repeat the examination, the dose we always record it. The main method of radiation dose monitoring used in radiography is the DAP, the dose area product, which is measurement by the kV, the MAS, and also the area of exposures, which is how large the collimator open. So therefore, for the safety radiation dose, collimator is still played important roles as well as well as the parameters. And with the Siemens, we have virtual collimation and auto thorax collimator. This will help you about that.
All right. So that means the systems basically help to reduce the dose for the patients, not only during the procedure, but if there is any possibility for a repetitions or anything, the radiographer is always informed on the dose that we're going to give to the patients, and also whatever record that the dose that already given to the patients. That's very nice. Thank you.
Okay.
All right. So let's go to the CT scans. We have a few questions on the CT scan. So I'd like to invite Miss Bowie.
Okay. Yeah. Thanks, Niam.
Hi, Bowie.
Hi. Yeah. So
yeah. So we have the first question.
Yes. When do we use retrospective or prospective trigger? Well, it really depends first on the doctor, right? So, and also what you want to look at. So with retrospective, as I've mentioned in my presentation, it's more dose, but there is more flexibility. We can actually do things like ECG edits. So if the reporting doctor is actually looking at doing cardiac function as well, then we actually go to retrospective. For most other studies, if we are just going to go for the regular screening, we don't want to give so much radiation dose to the patient. So then prospective trigger is always the preferred method. So I would say at the end of the day, it's the decision of the reporting doctor. So we do have sites where it's a cardiologist site and they prefer to have cardiac function done all the time. So for them, regardless of the heart rate of the patient, they choose to do retrospective. But in most of the diagnostic side where we're talking about radiology department, we're actually doing prospective trigger.
All right. So that means that every dose that we give to the patient is always justified. So whether we are choosing a retrospective or prospective, there's always reasoning behind. Is it correct?
Yes, that's right.
All right. Very good. Yeah. We have a second questions over here. This is the common questions when we talk about CT cardiac. So about arrhythmia or irregular heart rate.
Yeah.
What is the best scan mode actually for patients with irregular heart rate?
Okay. Yeah. So if everyone do remember during my presentation, I did say that when we are talking about regular heart rate, we are scanning at diastole because as a longer RR interval, this is actually in relative percentage. And if there's arrhythmia or high heart rate, that RR interval changes, it's not regular, we can't use percentage anymore. So in these cases, what we're doing is going to scan in systole and we're going to use the absolute. So we're going to scan in milliseconds, and usually that is in the range of about 200 to 400 milliseconds that we're going to use, because regardless of the change in heart rate, that time frame is almost stable for all different heart rates.
All right. So that means depending on the patient's heart rate, we have to choose the correct phases to scan. And then does it mean that the responsibility falls to the radiographer alone, or do you have something that allow automatic selections on the scanning phase?
All right. So for most experienced radiographers, they know where to pick and change the pulsing timing frame and on the trigger tab. For newer radiographers, of course, on our scanners, we actually do have guidance. All right. So if you leave it on auto instead of manual, based on a lookup table in the background, this heart rates and irregularity has already been defined in the background, and the system is actually able to pick that up if you leave it on auto. And the system will also try to change the parameters on the trigger tab to match these, so that you don't have to be the one picking the parameters. But that being said, most of the time for experienced radiographers, they are seasoned, they know what they are doing, so they already know what to pick. But if you are new or you need more guidance, use the auto feature on the trigger tab. The system in the background has a lookup table that can guide you to choose the correct mode.
Yeah, that's very nice. It means that regardless who's the radiographer, whether they are junior radiographer or senior radiographer, they can always perform CT cardiac, isn't it?
Mm-hmm.
All right, good. So let's go to the next questions. Questions number 3. So this is the question is CT scan specifically for cardiac. What minimum hardware and software specifications do we need to have?
Okay, so this is quite not really an application question. It's more like a sales and marketing question, I would say. I would say any scanner, honestly, from Siemens, we can do cardiac on it. It's just what is your requirement. If you're just doing basic screening, you have a budget limitation, get our single source. It's good as well. So the only thing to note is if you're doing screening and single source CT cardiac, then we have to make sure that patient's heart rate is really controlled during the scan itself. Of course, then if you have the budget, then the best recommendation is always our dual source.
All
so
right.
that you get good temporal resolution. Software-wise, well, we always have the scanner, and then the post-processing would be on our single VR. Mm-hmm.
All right. So that means the basic standard requirement for cardiac, which is 64 slices and above, we definitely can do the cardiac, and then we do have a single VR for the post-processing itself. Yeah. All right. Yeah. Okay. All right. Good. And I'm sure that definitely we do have a lot of automation on the scanner itself and also on the single VR itself. So that means this is depend on the hospital to choose what they want, which automations that they want, isn't it?
Yes.
All right. And we do have another questions actually for CT scan. Mm-hmm. And if the patients came for the coronary artery disease and aortic dissections, can we do a single scan to get both?
Okay, the answer is yes. So this is actually like a double rule out. We can also do triple rule out. So if you want to rule out pulmonary embolism as well, that's a triple rule out. So either way, whether we're doing a triple rule out or double rule out, we do have this chest pain protocol on our scanner that we can use. So what we have is an ECG gated scan that can scan the entire chest. in this case, if you need the whole aorta, we can extend it down to the pelvis, and then we have a gated scan right over the cardiac area for the coronaries itself as well. So it's a matter of picking the correct protocol. So that being said, the chest pain protocol in general is a retrospective gated scan. So it's a little bit of radiation, high on the radiation dose side, but if we really need this to be done and the benefit actually outweigh the radiation dose risk, then yep, by all means we can just pick that protocol to do. So at least we are only doing one scan to rule out three things or two things rather than doing 2 or 3 separate scans.
Yep. I can imagine that if the patients came with the chest pain and then the doctor unable to rule out whether it's a coronary artery disease or aortic dissections, time is very crucial. And like you mentioned, the CT protocol chest pain definitely will have to speed up the examination so the doctor can proceed straight away with the patient's management. Yeah. We do have one more question for you, Bowie. And the next question would be, does 400 Augustin score contraindicates coronary CT? I believe this is already answered just now, but maybe you want to elaborate a little bit more.
Okay, yeah. So I believe this was because there was some literature out there that had suggested previously that, when we have a Augustin score of 400, then probably will not proceed on with the angiogram for the CT scan. Well, so the rationale why this was suggested is basically because of the calcification in the coronary arteries. So it could be very dense calcification, and in that case, we might not be able to penetrate sufficiently, and that would cause blooming artifact. It's going to affect how we can actually assess the lumen itself. So that was why there was the literature suggesting this. However, this is actually really based on a doctor's preferences as well. So some doctors would go all the way to as long as it's below 1,000, they would go ahead with it. All right, so for me, I think a rule of thumb is to look whether the calcifications are actually very scattered or are they really dense and concentrated on a vessel itself. Because if it's scattered, I don't think it's a really big problem to go ahead with the CTA. But if it's really dense on that vessel, then it's probably quite pointless to shine the patient, do the scan, and then not be able to assess the vessel at all. That being said, at the end of the day, this is always the doctor's decision. So in my personal experience, this has always been the case where we will actually have to call up the reporting doctor of the day to actually check with them if they still want to go ahead with the study.
All right. In terms of the technical part on the protocol, is there anything that we can do to actually reduce the risk of blooming artifact or maybe whatever artifact that can be caused by this calcium?
Yeah. So as I was mentioning earlier, the blooming is usually due to the insufficient penetration. So we know that on our scanners, we have care KV, and then the system will actually pick the correct KV based on the body size of the patient and also because of our isocentering position. So if it's a skinny patient, the system would probably pick a 80, 90 KV for the scan. All right. But in this case, if it's a skinny patient with very dense calcium and we want to reduce the blooming, then we have to go on to semi-care KV, all right? And then we pick 120 to try and reduce. So the key word here is reduce. We cannot remove the blooming entirely. We just try to reduce it. So in terms of scanning parameters, we try to use a higher KV to increase the penetration to reduce the blooming, because blooming is actually still beam hardening at the end of the day. Reconstruction wise, we will want to reconstruct with a sharper kernel. For example, we have a stent kernel which is BV49. So if we use that, we get a sharper image, and then we would probably be able to visualize the lumen a little bit better beyond the calcium itself.
All right, excellent. Thank you, Ms. Bowie.
Thank you.
All right, so let's go to MRI. I'd like to invite Mr. Yus Hafizal. Hi, Mr. Yus.
Hi, I'm here. Yeah.
All right, good. So we do have a few questions actually for MRI. So let's go to the first question. How long do we need to wait to do cardiac MR post-cardiac stenting?
All right, okay. Thanks, Niam. And thanks for very good questions coming from your participants. For your information, the currently available stents are predominantly made of low carbon stainless steel and also titanium. So there's a lot of evidence supports the safety of MRI after coronary stenting in general. However, Careful risk assessments should be undertaken for an individual patient with regard to the type and also location of the stents. And of course, the timing of the MRI after the stenting. I can share with you, even for some center, they also do it next day following the post-stenting.
All right. So this trigger a question actually from myself. What's the reason for the time gap between the stent procedure itself, the PCI, and the MRI? Why they have to wait maybe, let's say, 24 hours or whatever hours, other than, of course, patients have a femoral puncture? Is there any reasoning behind?
There's also some reported cases where the stent can be mislodged, but I do find it is really a seldom cases. So for just a safety measurement, maybe we wait for 24/7 due date, durations. Then only we can go with the cardiac MR.
All right. So that means first we have to know what type of the stent. So probably we should be in contact with the stent manufacturer or see the label itself. And then just do like a time gap just to make sure that the stent is properly positioned and basically stick to the lumen of the coronary itself. All right.
Yeah. And I would like to add one more additional information. Sometimes we also need to either check with the vendor whether the stent are basically good for any type of MR strength, which is 1.5 or 3 Tesla. Nonetheless, I do believe there's a lot of information that coming, and you are very basically good to undergo the cardiac MR even for the next 24 hours post-stenting.
All right. Okay. Interesting. Thank you. So let's go to the second question. This is questions regarding the LV function. So can I define the reference or normal ranges? I believe they want to define by themselves. Is it possible?
If you ask me, yes, definitely we can do that, because if you are using our single VR platform and it's starting from VB40 software version onwards, you can choose a different reference, which by simply update the new reference journal in your MR cardiac analysis. I do believe this is considered able to do via remotely by your application specialist, your local application specialist.
Okay, that's very nice. So that means the Singovia have a full flexibility for anyone who want to do research. So they can key in their own parameters and then see the analysis that come up from that particular patients with their own specific parameters, isn't it?
True. Just one more information. Currently, we are using Lawrence Journal guidance for the reference value. So I believe there's a lot more papers coming up, and some people would like to have the latest information from the journal that you can update it on your own. Should be no problem.
All right. Very nice. Interesting. So we have the third questions over here. How fast can a viability study to complete? And is there any offering from Siemens for faster scanning and free breathing examination?
Oh, okay, right. Yes, I really love these questions. I can happily inform you that we have offering in order to complete the viability study within half an hour, 30 minutes, or even within 12 minutes protocol. In Siemens, we have Go Help protocol to improve and shortens the routine viability study. This is coming with the cardiac dot engine and also compressed sensing offering. And with the 12 minutes protocol, Siemens offer a set of sequence that can be used for vulnerable patients which can't hold their breath, which means you can definitely run a full free breathing technique from Cine up until your leg gap technique. And for further details, I must suggest you to contact our local Siemens representative. Do remember, extra license is needed for this capability.
Oh, all right. That's very excellent. Already when we state that the scan is already like 12 minutes, that's considered very fast, especially for patients with the heart conditions. They definitely do not like the gantry. And if we can make the examinations faster, that's definitely advantageous for the patients. All right. Let's go to the next questions. Questions number 4. So the doctor preferred to do the CMR on the 3T as the image signal is better. However, there can be a potential problem in image quality like of resonant artifact and flow artifact. Can you share some tips and tricks that can help to overcome these challenges?
Of course, some center only had 3 Tesla system which equipped with MR cardiac protocol. And I do believe we always like to have 3 Tesla because of the improved signal to noise ratio. But one thing we need to bear in mind that in 3 Tesla, we might encounter issues like off-resonant artifacts. I always advise radiographer to run the frequency scope in order to make sure the images less or even free of artifact. This is one tips to improve your cine images, and focus on your frequency scope, and definitely you will have better images. Right? And of course, while talking about flow artifact, we simply just need to run phase swap images to change the artifact directions.
All right, that's very nice. So, basically, for someone who didn't know MRI much, it is really important to know the system capability and then to do things in the correct order for the system to give us the nicer image quality. All right.
Yeah, true.
Thank you, Mr. Yus. Thank you so much for the answering all the MRI questions. So I would like to go to our next panelist on the nuclear medicine. All right.
Hi, Niam.
Hi. So we do have here the first questions. What workaround can be applied in MPI for patients with irregular heart rate?
Yes. The recommended acquisition mode in the performance of MPI is a gated tomo acquisition. So when you look into the gates tab, it is usually set into 40% bit histogram window. And if your patient has arrhythmia or irregular heartbeat, we can set this bit histogram window to be increased to as much as 60%. So you can choose from 41 to 60% bit histogram window and observe the rejected and accepted beats. Of course, we want to have a ratio of our accepted beats to be greater than our rejected beats. But of course, with patients with severe arrhythmia, this workaround is not helpful because the arrhythmia is, or the heart rate is too low or too high to be captured by our system. So one workaround that we can apply, but this is with the discretion of our doctor, is to perform a tomo acquisition instead. So we will let go our gated acquisition, and we can still rule out our ischemia or infarction in our myocardial perfusion, as well as viability without the gates. Of course, our result will be limited in a sense that we cannot compute for our ejection fraction when we have this in our gated acquisition.
All right, thank you, Adrian. So definitely that the system is capable to be customized according to the patient's heart rate. So, and if that's also not possible, so there is always another protocol that can be used, which is in this case, the TOMO itself, isn't it?
Yes, definitely.
All right, so let's go to the second questions. Can we scan situs inversus patient?
Yes. I think I answered this already in the chat box. So normally, our acquisition mode is our detector systems will rotate 180 degrees towards the left side of the patient where the heart is. So in the case of situs inversus patient, where the normal organs, which is situated in the left, are in the right, we need to configure our detectors to rotate towards the right side of the patient instead. So yes, we can accommodate patients with situs inversus.
All right, so this means that we need, or the hospital need, a very flexible system that allow maybe more than 360 degree of rotation, isn't it?
Yes, correct. That's correct, Liam.
All right, good. So let's go to the next questions. This is CT. If the CT attenuation correction is not available, is there any technique that can be done to minimize attenuation's artifact?
Yeah. So we recognize that some systems are not hybrid. So we have only spec-only systems. So the workaround we can recommend to these users with this system is to place the patient in prone position. So of course, when the patient is prone, we cannot totally obliterate the attenuation artifacts from the diaphragm for male patients, for example, and the breast attenuation artifacts for females, but we can minimize Yes, we can minimize this attenuation artifacts when we scan our patients in prone. Of course, we need to configure again our system, our detectors to rotate on the other side because your patient is lying prone. So normally the detectors are rotating um, clockwise. So we will shift to a counterclockwise position, and our detectors are at the bottom of our scanning bed. So
All right. Yep. And I believe all these rotations can be done automatically with like a safe position or something.
Yes, that's correct, Niam.
All right. That's very nice. Thank you, Adrian.
Thank you, Niam.
All right. So let's go to Angel Advanced Therapy. Let's invite Miss Hong in. Hello. Hi, Hong In.
Hello, can you hear me?
Yeah. Now we can hear you.
Can you all hear me?
Yes.
Yeah, thank you.
All right, okay. So now we have questions for AT, for Angel Advanced Therapy. So the first question, what are the requirements to have a clear stand live function? Or maybe you just describe a little bit what is clear stand live functions first. Or maybe some of our participants, maybe they're not familiar with the angiography system. What is the clear stand live?
So clear stand live function allow you to see a structure of stand. It's very important when you're inflating the stand and you want to see like the structure. Is it under expand, or is it when you put two stand overlap together? So you want to see the position of the second stand with the position of the first stand. So it's very, very important. So that's why we use the clear stand line to focusing on more the stand structure.
All right. So basically, yeah, sorry, continue.
Yeah, and the requirement to have the clear stand live function is you need a license, and your RT system need to have the software with the VD11 onward.
Oh, all right. That's very nice. Then I assume that this clear stand live allow us to see the stand without motions, isn't it?
We have the clear stand line. So if you're using the clear stand line protocol, so one monitor will show you a live images, and the other monitor you see the stand, and you can move the devices, and you can see the movement of the devices when the doctor is navigating the devices.
All right, and I believe the name live itself means all these are in real time.
Yeah, it's in real time.
All right, thank you. That's very nice. And now we can see something on the heart that actually frozen, not move as what we usually see, so that the positioning of the stand can be more accurate and precise. Yeah. All right, so let's go to the questions number 2. Is it possible to lower the radiation exposure during PCI? What can I do? And then what will be the effect on the image quality?
So actually during the PCI, you can choose the different protocols. If you want a low dose protocol, you can go to the artist's workplace to change to the CARE protocol or XCARE protocol or XXCARE protocol. So they are low dose protocol. And if you're doing the fluoroscopy, please select the minus fluoroscopy protocol. This is the low dose. And also you can go to the touch screen to change the protocols in between. If you're choosing the low dose protocol, your image might get a bit noisy compared to the standard protocol or the default protocol.
All right. But I believe that low dose protocol with probably slightly noisy images is fine, especially when the doctor just wants to move the wire, not really, let's say, doing a critical thing such as positioning the balloon or the stand, isn't it?
Yeah. Yeah.
All right. Yeah. That's very nice. And one more, you mentioned about the touch screens just now. So that means the angiographer can change the protocol live during the case without needing him or her to actually go out to the control room.
Yeah, that's exactly. So when the doctor want to change in between each protocol, he can just go to the touch screen and control that. They do not need another radiographer to control outside.
All right, that's very nice. The last people inside the radiations room or the examinations room itself.
Yeah.
All right, so let's go to the third questions. On angio, I assume here, what will happen if the patient is not at ISO center and we activate the safe positioning? Is there any anti-collision features on the angio system?
So it's recommended when you are doing the biplane, you need to isocenter because if you do not isocenter, when you rotate the C-arm, it might get off a bit for the AP plane and lateral plane. So it's recommended when you're doing the biplane system. And you still can save the patient, still can save the position if you do not isocenter. Is there the anti-collision feature? Yes, our system equipped with the collision sensors, like for example, at the detector, at the X-ray tube, at the back of the C-arm, and it very depends on the system that you have to. Please prefer to the operator manual, or you can ask your application specialist for more details.
All right. Okay, that's very nice. So that means the system gives the full flexibility. It is recommended to set it in ISO center, but then again, it's a full flexibility on which positions that the radiographer or the angiographer want to save. And if they need to move the system, there is always the collision switches that help to maintain the patient's safety. All right, that's very nice. So let's go to the fourth questions here. During the PCI, is the patient's skin dose get higher or lower if I reduce the height of the image intensifier or the detector in this case?
When you're reducing the FT or lowers your FT height, so the tube doesn't need to put more power to penetrate, so you lessen the skin dose for the patients. Additionally, just please keep the table height constant because when you lower the table closer to the tube, you're increasing the patient's skin dose.
Okay, so the patient's skin dose will increase if, let's say, we lower down the table itself, which means now the patient's closer to the tube itself, right?
Yeah, that's correct.
All right, good, very good. And do need the angiographer, they need to adjust this manually every time that they change the C-arm positions, or do you have something on your system that allow to maintain the distance of your flat detector or the detector itself on to the patient?
So you mean the lower the FT height?
Yep, to lower the FT.
Yeah. So if you go to the examination room on the joystick of the stand control module, at the back of the joystick, you have two buttons, one to lower the SID and one to raise the SID.
All right. Okay. So that means it's very easy for them to control the SID. All right.
Yeah.
That's very nice. Thank you very much, Ms. Hong Yin.
Thank you. Thank you.
All right. So let's go to the last modality that we have here. So we do have for the single. All right. Get Hoon. Hi, Ms. Get Hoon. Are you there? I cannot hear you. Did you unmute yourself?
Can you hear me again?
Oh, all right. Now we can hear you.
Sorry.
Oh, it's okay. All right. So we do have a few questions for single here. Yeah. This is very interesting modalities actually for single because we had single almost in every other modalities, but yours basically it's very special. So you talk about the single dynamic just now. So we have a questions here asking what's the difference in single dynamic and normal pack.
Okay, So maybe I just give some definitions on the PACS. PACS is actually stand for Picture Archiving and Communication System. So it's actually storage for the images. Okay, whereas for single dynamics is actually a cardiovascular information system. Okay, it is not only for picture archiving, but it's also for the reporting. As what I mentioned in my presentation just now, we have reporting for different kind of modalities. We can do the reporting for angio, we can do reporting for echo, for nuclear med, and for MR, and so on. So it's a complete system just designed for the cardiovascular examinations, and it is good to use in the cardiology department.
All right. So that means this is a very dedicated system, especially for the cardiovascular, where all modalities with regards to the cardiac is combined with one central modalities, so that the doctor have the flexibility to choose between images, review between reports, and probably also create their own template of report, right? So this seems like more advanced than the standard PACS.
Sorry, can you repeat your question again?
No.
Is it?
Yeah, it's not, yeah. It seems like this is much more advanced than the standard PACS, right?
Yeah, correct.
All right.
Yeah, because for the radiology, usually the doctor will use dictations or the voice recognition to do their reporting. But then for the cardiology, they tends to do the structured reporting, whereby we need to really design the template for the radiology so that when they select a certain option in the report, the text will be automatically generated according to each options that they selected in their report. Okay, and all this text can be customized for different hospitals. It is not standardized. We can customize it according to our user preferences, and the user also has the capability to change it if they need the changes to be done, let's say due to the changes from the guidelines.
All right. Yeah, that's very interesting when you mentioned about the cardiologists prefer drawing, and then now the drawing is done on the computer, and then all the information is automatically populated into a preset template. That's very nice. Yeah. So
they don't have to read out all the text, but they just do some clicking. They just select whatever they need in the template.
Yeah, that's very interesting. We just come to the next questions. Is it possible to integrate hospital information system with the single dynamic? Because I believe that the single dynamic is dedicated for the cardiology, while the whole hospital probably already has hospital information system. How about the integration?
Okay, so I would say yes, we can integrate single dynamics with most of the hospital information system and also the radiology PACS. Okay, in some of the hospitals, they already have their own radiology PACS system, and they have their radiology information system as well. So in this case, whatever report that is done in single dynamics, we can send the report to the EMR, to the HIS, and also back to the radiology information system if the radiologists would like to have this report in their system as well. Same thing, we also can share the images that we stored in single dynamics to the PACS system and vice versa. Okay, meaning the radiology PACS also can send their reports and also can send their images to single dynamics as well. In this case, both the radiology and the cardiology department can work closely together, and then they don't have to like call each other very frequently just to update whether they have the report done or not.
Yes. That's a very nice features in terms of the compatibility. That means doesn't matter whether the hospital already have 5 years old or maybe 2 years old hospital information system. The single dynamic can always integrate it together to allow a comprehensive network within the department, cardiology to radiology, or to the whole hospital. All right, very nice. So we do have another questions for you. So that single dynamic on mobile phone, is it optional? So I think that they impressed with the video just now where the doctors can review the images via phone. Now they ask whether this is an optional.
Okay, so it is really a very, very good features, right? To have the capabilities to view the images on the phone or tablet or any other mobile devices. And I have a good news here is that this is not an optional features, but this is a standard features for single dynamics. Because for single dynamics, we offer three kind of client, okay, which is first the workstation, secondly is the remote workplace, and thirdly is what we call the web portal. Web portal is the one that we saw just now, which my colleague demo on his iPhone. Okay.
All right. So the other questions that probably people will ask when we talk about mobile, how about the data security? Is it like the patient's privacy can be maintained if it's on the web base?
Okay, so only the person with the access right could access to the web portal. Okay, if let's say this doctor, they do not have the access to the hospital network, then they won't be able to log into our web portal even though they get the link. Okay, they need to have a certain permission from the IT administrator, then only they have the access to the studies and also the patient information.
All right. And since this is a web based, so it doesn't matter if the doctor are using iOS or Android, right?
Exactly. Yeah, we supported both Android and also iOS, and you don't have to install any applications on your mobile phone. It is not an application. You can just open up the your Safari or your Google Chrome, and then you put in the link, and you will be able to access to your patients.
All right. That's very nice. And then we can imagine that this is like a pack dedicated for the cardiac. So that means we can, or the doctor can actually review not only an angio images, maybe all other report from the nuclear med, from the CT, whatever that related to the cardiology, right?
Yeah, correct. And Niam, maybe one more thing I would like to add on here, because most of the time when the clinician access to the patient information, maybe they will open up on the EMR system. So we also have the capability to deeply integrate with the EMR. We can put a link on the EMR, and then when the doctor click on that particular link, they will be able to launch the single dynamic viewer so that they can review the images.
All right, that's very nice. So this is very advanced integrations and collaborations. And all this, I believe, with the same objective, which is the precise medicine for the patients, giving the best care, giving the best procedure or clinical the treatments for the patients, right? All right, so that's all questions for Singo. Thank you, Ms. Kirsten.
Thank you, Niam.
All right. And for all the participants, we actually comes to an end of our sessions. So I would like to inform that we're going to have the next Arise Neurology in August. The date is not yet confirmed, but stay tuned. We will send you an invitation via your local marketing team, Siemens Healthineer marketing team of your country. So they will inform you the exact date for the Arise Neurology. Since basically same method that we're going to do, which is basically we will choose one clinical indication and then we will do the discussion in multimodality, try to link each other so that the participants and all of us can see the correlations on how the modalities complement each other for the best patient care. All right. So again, on behalf of Siemens Healthineers, I would like to say thank you very much for staying with us for almost the whole Saturday. And before we leave the session, I would like to encourage everyone to actually fill up the survey form so that we can do some improvements. And then, of course, for those who want the certificate will be given within next few weeks. We will send it via your Siemens country representative. All right, so I guess now we are on time. So thank you very much again on behalf of Siemens Healthineers. I hope that we can benefit from the sessions today. If you do have further questions, do not hesitate to contact us, or you can contact straight away your Siemens Healthineers representative in your country. Yeah. And again, thank you and see you in the next Arise.